ജീവിതത്തിലെ വേദനകളെ അവരുടെ ജീവിതത്തിൽ സൗഖ്യത്തിലേക്ക് നയിപ്പാൻ തക്കവണ്ണം അവിടുത്തെ ഈ പ്രിയ മക്കളുടെ ഓരോരുത്തരെയും കരങ്ങളെ അവിടുന്ന് ശക്തീകരിച്ച കൃപകൾക്ക് നന്ദിയുടെ സ്തോത്രം. തുടർന്നും അങ്ങയുടെ കരങ്ങളിലേക്ക് സമർപ്പിക്കുന്നു. കർത്താവേ, ഈ മീറ്റിംഗ് ഏറ്റവും അനുഗ്രഹത്തിനും വിടുതലിനും കാരണമാക്കി തീർക്കാൻ നന്ദിയുടെ സ്തുതിക്കുന്നു. ഞങ്ങളുടെ കർത്താവേ, ജ്ഞാനത്തിൻ്റെ കൂടുതലായി വർദ്ധിപ്പിക്കുവാൻ തക്കവണ്ണം ഈ ഒരു മീറ്റിംഗ് സഹായിക്കുന്നതിനായി നന്ദിയുടെ സ്തോത്രം. എല്ലാ നന്മകൾക്കായി നന്ദിയുടെ സ്തുതിക്കുന്നു. പുതുവാതിലുകൾ അവിടെ നൽകി അനുഗ്രഹിക്കുന്നതിനായി നന്ദിയുടെ സ്തോത്രം. എല്ലാ സാവകാശത്തിനായി നന്ദിയുടെ സ്തുതിക്കുന്നു. യേശു രക്ഷൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. എല്ലാവർക്കും ഇരിക്കാം.
Thank you, Father. I'd like to invite Dr. Chepsi Philip to welcome the gathering.
Thank you all for taking your time out to attend this CME Hematology Horizons. Beyond this, it is a very momentous occasion for our institute as such. It is 10 years of our foundation. Today is our Decennalia Excellencia, and as a department, we are honored to host the CME for this year. And we are very, very proud to have such an expert panel of luminaries who are going to add their experience and value to the CME. Thank you so much. We intend to use the CME to throw light on interdepartmental collaborations, consultation to help improve care, not specific to hematology as such, but in routine clinical practice. And I hope you will take away good takeaway points which will go on to improve your patient service wherever you are from. Thank you so much for attending, and we hope you will enjoy your stay with us. Thanks.
Thank you, sir. Let's dive into today's sessions. Without further ado, I'd like to introduce our first speaker, Dr. Sriraj Vasudevan, Assistant Professor, Clinical Hematology, Amla Institute of Medical Sciences. He brings a wealth of knowledge and a fresh perspective to the field of hematology. As we prepare to hear from Dr. Sriraj Vasudevan, let us embrace the opportunity to learn from his expertise and passion for advancing healthcare. Please join me in extending a warm welcome to Dr. Sriraj Vasudevan to enlighten us with the first session of the day on hematological aspects of systemic diseases. I also invite the moderators for the session, Dr. R.N. Sharma, Professor of Medicine, former HOD, Pushpagiri Institute of Medical Sciences, and Dr. Mohan Varghese, Associate Professor of Medicine, Believers Church Medical College Hospital.
Very good morning to all of you. First, let me thank Dr. Chepsi and team for giving me the opportunity. Also, chance to co-chair with Doctor. Now, the topics are excellent ones and very useful for the general physician, all alike. The topic given now today is we are starting with hematological aspects of systemic disease. We know that all systemic disease, cardiovascular system, renal system, hepatology, everything will have an impact on the hematological aspects. It will impact the bone marrow. Now, lot of conditions can produce changes in the bone marrow, as well as it can produce alterations in its function. So hardly all of them, all the systems are working in unison as an orchestra. Therefore, it is important that a physician should know what is happening in this environment. Now, the presence of liver disease can produce thrombocytopenia, sometimes thrombocytosis. Renal failure can produce anemia, and sometimes a tumor is there, it will produce polycythemia. To discuss this, we have got Dr. Sriraj Vasudevan, well-known hematologist. And before that, you are going to talk? Hello? Okay. Now, over to Dr. Sriraj.
Thank you, sir. Good morning. Thank you, Dr. Chepsi and team Rectum for inviting me here. and it's an honor to talk before the chairpersons, my excellent teachers in the field of medicine. So I'll be talking about consultation approach to anemia and pancytopenia, thrombocytopenia, and some part of plasma protein related consultation. Clotting and thrombosis is dealt by the subsequent speakers. So most of our consultations in different departments leads to consultation regarding anemia. So when you see an RBC maturation, RBC basically goes into the maturation in the bone marrow is a successive steps where the precursors acquire hemoglobin and exclude nucleus. The final step in the bone marrow is reticulocyte, which is a nucleate cell with RNA content in the cytoplasm. They stay usually around 3 days in the marrow, and then they released into the blood as immature erythrocyte or reticulocyte. They stay in the blood for around 1 day, and then after removing or losing the organelles and RNA, they become mature erythrocyte, and they last around 120 days. So this reticulocyte duration of the span of reticulocytes in the marrow and in the erythrocyte in the blood is important with respect to the anemia evaluation. Normally, when there is an anemia, when the marrow is adequately responding, there will be an exuberant reticulocyte response to overcome the anemia. So that exuberant response leads to early release of reticulocytes into the circulation. So the circulating reticulocytes, actually the duration of reticulocytes circulation in the blood increases to more than 1 day, and the percentage of reticulocytes also increases with respect to anemia. So when you ask for a complete hemogram as you evaluate your patient, basically the results come from the machine called Coulter, which works on a principle called photo. They basically measure the cell size and cell granularity based on the laser principle. The cells are moved in a single column and the light source is emitted, and depending upon the reflection of the light, the cells were differentiated based on the size and granularity. There is a forward scatter which assesses the size, and the side scatter which assesses the granularity. So when you introduce blood into the machine, any cell more than 30 femtoliter will be measured as RBC. Any cells between less than 30 femtoliter will be measured as platelet. And WBC, depending upon the nuclear size, they will be differentiated between lymphocytes, mononuclear cells like monocytes, granulocytes, basophils, and neutrophils. So the point here is the differential which we get from a complete hemogram is a machine-made hemogram. So it can be of fallacy. Like suppose if a platelet count, platelet size is more than 30 femtoliter, it will be measured as not as platelet, maybe as RBC. So that kind of inaccuracy will be there in the hemogram. Even though the latest hemogram machines have adequate facility to find out the faults, the abnormal cells, but even though we have to keep in mind that the CBC or complete hemogram is not always the final report, and we have to counter check that hemogram report with a peripheral smear. So when you see MCV is the mean corpuscular volume of the RBC of the given sample. Normal range is between 80 to 100. MCH is the mean corpuscular hemoglobin. When you have when your population of RBCs have equal size, then your red cell distribution will be narrow. So when your RBCs have different sizes and different shapes, the red cell distribution will be increased. These are the parameters which we focus on anemia evaluation. Coming to reticulocyte, we already saw that reticulocytes circulates in the marrow. It can be stained by supravital stains in the peripheral smear. Automated hemogram counters can give a reticulocyte percentage nowadays, or the pathologist can give you a reticulocyte percentage. Now, when you get reticulocyte percentage, we need to correct that reticulocyte percentage for the degree of anemia before evaluating for the anemia. So normally when you have anemia, there will be, if the marrow is normal, there will be high 15 to 20 fold increase in production of reticulocytes. But but as you see in this picture, as the RBCs keep on decreasing, the reticulocyte percentage is curiously increasingly represented because of the decrease in the denominator. So we have to correct the reticulocyte for the degree of anemia, that is corrected reticulocyte count or reticulocyte index. And we differentiate the anemia based on reticulocyte production index. If the reticulocyte production index is less than 2.5, that is a hypoproliferative anemia. That means the marrow is inadequately supporting the anemia. And reticulocyte production index more than 2.5 is hyperproliferating anemia. So after this history and physical examination, and after the initial hemogram and the reticulocyte count, we can differentiate anemia into differentiated based on reticulocyte production index of less than 2.5 and more than 2.5. More than 2.5, only two causes, either a recent blood loss and response to that blood loss, or hemolysis. If the reticulocyte production is less than 2.5, it's basically then the subsequent evaluation is based on the RBC morphology, whether it is normocytic or microcytic or macrocytic. So if it is microcytic or macrocytic, there is an element of nutritional deficiency can be there, iron deficiency or B12 deficiency can be there. Or if it is not, if the nutritional deficiency is ruled out, then other causes are normal, usually bone marrow diseases. And when we know that iron deficiency, the iron parameters in iron deficiency, the ferritin will be low and the transferrin saturation will be elevated. But when there is an inflammatory state, or when there is a chronic disease like CKD, the ferritin, being an acute phase reactant, will be increased. So it will mask the iron deficiency. In that case, we have to depend upon the transferrin saturation. If the transferrin saturation is less than 20 with a ferritin of less than 100, even in the setting of chronic disease, it can be a functional iron deficiency. The important point here is the functional iron deficiency can be benefited from IV or parenteral iron therapy. So whenever you are evaluating patients with anemia in an inflammatory state, kindly we have to include ferritin and transferrin saturation. A word about hemolytic anemia. Normally hemolytic anemia, when in the marrow, the reticulocyte stay for around 1 day and then they are released into the blood. They travel for around 120 days and then they get they get opsonized and damaged inside the reticular endothelial system, and the byproducts are hemoglobin, byproducts are urine hemosiderin and the bilirubin. Now, when your lifespan is decreased due to hemolytic anemia, any cause of hemolytic anemia, the RBC lifespan decreases from 120 days to 5 to 10 days. So there will be a very short span of RBCs. So there will be increased destruction, and that destruction put a load on the reticular endothelial system, resulting in high bilirubin, high LDH, and the reticulocyte in the marrow, because of the high reticulocyte turnover, the reticulocyte percentage also increases in the peripheral blood. So hemolytic anemia can basically differentiate into a autoimmune hemolytic anemia and DAT negative or direct Coombs test negative hemolytic anemia. So when you suspect hemolytic anemia, the next ideal investigation is a peripheral smear to look for the etiology. You can see spherocytes, you can see schistocytes, you can see schistocytes in the TTP, you can see bite cells in G6PD deficiency, and you can see agglutination, cold agglutinin disease, and autoimmune hemolytic anemia. So I'll be presenting some cases depending upon this. So whenever you have anemia, after the detailed evaluation of clinical history and evaluation, we have to look for two parameters: MCV, reticulocyte production index, and MCV. So these are some cases which I found will be useful in this forum. This is a 64-year-old female who is on insulin for diabetes for last 10 years, diabetic kidney disease, stable creatinine. She presented with a history of fatigue. HB was 6.2. MCV was 83, normal MCV. Retic was 4%. Other complete hemogram parameters were normal. She received 1 unit of PRBC transfusion. LFT, there is no AG reversal. Calcium was normal. So because of the anemia, she was consulted for hematology consultation. So here the reticulocyte production index, we have to calculate reticulocyte production index. It is actually less than 2.5. So it's a hyperproliferative anemia with normal MCV. Next step should be an iron deficiency. To rule out iron functional iron deficiency, we have to do iron studies, and ideally, because she requires anemia requiring transfusion, bone marrow examination to rule out MDS because of the extremes of elderly age. So here the ferritin was less than 100 and the transfusion saturation was low. Bone marrow aspiration and biopsy were normal. So this is a typical presentation of functional iron deficiency in patients with anemia of chronic disease. These patients respond to IV iron. There's another consultation we get occasionally from nephrology. It's a CKD patient on dialysis on erythropoietin and IV iron supplementation. Recently, around 2 months, there is worsening of anemia requiring weekly blood transfusion. The nephrologist attempted increasing the dose of EPO and changing the product from the erythropoietin to erythropoietin, but it was not helping. The hemogram showed significant anemia. HP was around 4. MCV was normal. In the MCV was 94. Retic percentage was actually very low, 0.2%. Other differential TC and differential platelet count was normal. The other evaluations like stool local blood negative, urine used abdomen showed only shrunken kidney, no other node or splenomegaly. Myeloma workup, which was done for electrophoresis and calcium, were normal. There were no AG reversal. Albumin was in the lower range. Iron studies were normal. Here, if you see, the retic is actually very low. Retic production index is very low, and the MCV is in the higher range of normal range. So, because the patient is having very low HP with a very low reticulocyte count, she should ideally undergo a bone marrow. Bone marrow showed diminished erythroid precursors in aspiration biopsy. Diagnosis is PRCA, pure red cell aplasia, probably related to erythropoietin. Here we need immunosuppression treatment, immunosuppressive therapy for reducing the antibody clone. Here is another case. It's a elderly female. She came with fatigue and jaundice and high colored urine. Investigation showed anemia and very high MCV, spuriously very high MCV, high reticulocyte count, and rest of the investigation CBC was normal. LDH was elevated. The ultrasound abdomen showed splenomegaly, and CT done showed cervical and mediastinal lymphadenopathy. Here, the smear showed agglutination of the RBCs, and if you reticulocyte production shows hyperproliferative anemia. The spuriously high MCV indicates RBC agglutination in the sample. So ideally, we should repeat this test with a preheated EDTA tube or preheated peripheral smear slide. DCT showed complement C3D3+. Lymph node biopsy was showing lymphoma. So the diagnosis and malignancy induced called type autoimmune hemolytic anemia. Here we need steroids and rituximab therapy for reducing the autoimmune clone. Coming to one more case, this is a primary gravida, noticed anemia in the initial obstetric screening. Anemia was low grade, HP was 9.2, MCV was low, retic was low, 1.2%. Rest of the investigations are normal. So as she's having low reticulocyte production index and low MCV, the next step should be iron studies. Iron studies were normal. And we proceeded. The other cause of low MCV microcytic hypochromic anemia is thalassemia intermediate, thalassemia trait. So the hemoglobin electrophoresis showed beta thalassemia trait. So most of the pregnant ladies, if the iron deficiency is ruled out, we should look for, if there is microcytic hypochromic anemia, we should look for thalassemia trait. This is another interesting case which we saw last month. It's a elderly male on warfarin for rheumatic heart disease. He was admitted with a pain abdomen for 10 days after fall. There were visible ecchymosis on the anterior abdomen wall. USG abdomen showed a large collection of around 10 to 20 centimeter in the anterior abdominal wall. The later 5 needle aspiration showed blood. The aspiration showed blood. The initial investigation showed that the prothrombin time is prolonged, and the blood parameters showed low hemoglobin, normal MCV, high retic, and high LDH. Indirect bilirubin was normal. Indirect bilirubin was high. So if you see the peripheral smear, there were polychromatophils were there. Reticulocytes was increased, but there is no spirocytes, and the direct Coombs test was negative. So here, because the reticulocyte production index is more than 2.5, it is a hyperproliferative anemia. But this hyperproliferation is due to marrow hyperresponsiveness to the recent blood loss. The hemolytic kind of picture which you see in the high LDH and the indirect bilirubin high is due to the large hematoma resorption. So whenever you have a large hematoma, the resorption shows resorption will lead to an indirect bilirubin, high indirect bilirubin and high LDH. And the marrow recovery of this hemorrhage shows reticulocytosis. So it's the case of hematoma causing anemia and hemolytic kind of anemia picture.
Check.
This is another case which we saw recently from gastro. It's an 18-year-old boy who joined engineering recently. Once he joined hostel, he started avoiding the non-vegetarian food. He preferred vegetarian foods. He had vague abdominal symptoms, and he basically avoided spicy food because of the abdominal discomfort. The evaluation showed low anemia with low MCV, low reticulocyte production index. The differentials were normal. Liver function test shows albumin of 3 gram percentage. Creat was normal. So it's a male person who had previously was taking non-vegetarian food and spicy food, who recently reduced or changed to non-spicy and vegetarian food. Male patient with probable iron deficiency, we have to confirm the iron deficiency, and we have to rule out GI causes because he is a male child. So we evaluated and found that his CRP was elevated. Colonoscopy showed the ulceration in the ileum and the terminal ileum, and the biopsy came as Crohn's disease. So any male patients with a microcytic hypochromic anemia in any age group, an adult patient with microcytic hypochromic anemia, ideally need an GI evaluation. It can be undiagnosed or masked inflammatory bowel disease also. So anemia, my take-home point will be, after adequate history and physical examination, always start interpretation of the patient with a reticulocyte production index and an MCV, and we can classify the anemia based on that. Once hyperproliferative anemia, once your nutritional causes are ruled out, the common causes are marrow diseases. So marrow, there should be a low threshold for marrow after the peripheral smear examination. If it is a hyperproliferative anemia, you have to find out the reason for hemolysis, whether it can be an intravascular hemolysis or extravascular hemolysis. Now coming to the next part of my talk, platelet. So when you, in the marrow, the platelets are basically formed from the precursor called megakaryocyte. The proplatelets are basically split off from the cytoplasm of megakaryocytes. So the point here is, the analogy is like this: when you put a papadum into the floor, there'll be the pieces will be different sizes and different shape, but all will be tasting as papadum only. Similarly, when you make platelet, when the body makes platelet, the platelet sizes varies considerably. There will be large platelets and there will be small platelets, but all have the same function. So as I told you in the earlier slides, the size of the platelet matters in the platelet count. When you do a Coulter value for platelet count, if you have large platelets or if you have very small platelets, the Coulter may not recognize it as platelet, so there will be a spurious thrombocytopenia. So whenever you come across a thrombocytopenia patient, you always confirm that thrombocytopenia with a peripheral smear, and ask for a manual platelet count, and ask for the platelet clumps and large platelets in the peripheral smear. So we should ask for a machine count. And one of the commonest cause of thrombocytopenia without any bleeding manifestation is pseudothrombocytopenia due to EDTA-induced platelet aggregation. So ideally, when you suspect pseudothrombocytopenia, we have to recheck the platelet count in an citrate tube. So when you have isolated thrombocytopenia, ideally we should do a peripheral smear to look for manual platelet count, and we should recheck the platelet count in an EDTA smear. So we are not expecting any bleeding manifestation if the platelet count is more than 30,000. Severe bleeding manifestation usually occurs only if the platelet count comes below the 10,000 range. So if there is bleeding manifestation with the platelet count more than 30,000, you should find out another cause. It may not be due to thrombocytopenia alone. When you have bleeding manifestation, you have ecchymosis and purpura and petechia. One point to differentiate the purpura due to platelet or immune mediated platelet destruction is actually vasculitis purpura. Vasculitic purpura is palpable purpura. immune-mediated purpura and purpura is non-palpable purpura. We usually get consultations from dermatology for evaluation for bleeding manifestation of vasculitis patients, thinking that it is purpura. So palpable purpura is usually vasculitis. They have the anatomical distribution and they have associated symptoms of vasculitis. So there are other conditions where there will be low platelet, but there will be no bleeding. Actually, they will be having more thrombosis, like antiphospholipid antibody syndrome and heparin-induced thrombocytopenia. They both present with thrombosis rather than bleeding. The point here is they never have very severe thrombocytopenia. Like they usually have platelet count around more than 30,000. So very severe thrombocytopenia is not a feature of both of these syndromes. So coming to the cases in thrombocytopenia consultation, we have usually get patients planned for hernia or some basic surgeries. Pre-op checkup showed platelet count of 60,000 per microliter in the Coulter value, no bleeding manifestation. So they came for hematology fitness. So as I told you earlier, I will be checking the platelet count on citrate sample and I will be doing manual platelet count on peripheral smear. The peripheral showed EDTA-induced platelet clump and the citrate sample showed adequate platelet count. So this patient, whenever he will be testing the platelet count again, it will be like always the EDTA-induced platelet clumping will be there. So the patient should be instructed to check his platelet count in the citrate sample further. This is another case of which we come across in ICU when patients get admitted for patients get admitted for pneumonia or other significant infection. They will be put on many antibiotics and many other medications. So ICU, they will have progressive falling platelet count and they will have bleeding manifestations. The CBC showed platelet count of 30,000. They have smear showed normocytic anemia, neutrophilic leukocytosis, and thrombocytopenia. So because patient is in sepsis, so we have to rule out DAC first. So DAC, to rule out DAC, we'll do after the CBC and smear, we'll do a PT, epidety, and fibrinogen, and we'll have to review the drug history. The most common drug cause implicator in thrombocytopenia in the ICU is linezolid. Linezolid causes thrombocytopenia and can result in bleeding manifestation. So drug-induced thrombocytopenia is quite common, especially in rheumatology where there is a lot of drugs like methotrexate and leflunomide can cause thrombocytopenia and even pancytopenia. So drug history is, evaluation of drug history is very important. This is an interesting case of thrombocytopenia where a female G3P2 woman at 28 weeks of gestation came with bleeding manifestation like EC bruising for last 1 week. Her previous pregnancy was uneventful. She had platelet count of 19,000 on manual count. Her HP was low and her MCV was normal and her retic count was high. Her other investigations showed bilirubin mildly elevated, AST and ALT in the normal range. LDH was very highly elevated. PT, ABT was normal. Obstetric ultrasound was normal. But she is not giving history of blurring of vision or epigastric pain. Her blood pressure is always normal. So we proceeded with our algorithm. We did the reticulocyte production test, which is more than 2.5. It's normocytic anemia. Manual platelet count is low with bleeding manifestation. So in view of hemolysis thrombocytopenia, we proceeded with a peripheral smear and DCT and other immunological workup. Peripheral smear showed no spherocytosis. DCT was negative. ANA was negative. APLA workup was negative. But the peripheral smear showed many schistocytes. So the congenital TTP is a manifestation. Congenital TTP is a manifestation of it can present in the pregnancy. So we have to consider this also in mind. So whenever you get a consult for thrombocytopenia in the pregnancy, always include retic and LDH in the evaluation. This is another drug-induced thrombocytopenia. Patient presented with acute coronary syndrome. Patient underwent thrombolysis. The day of thrombolysis, the platelet count was 2.4 lakhs. After 24 hours, patient had bleeding manifestation. The platelet count showed was very low. So we ruled out the coagulopathy. Smear showed severe thrombocytopenia. Here, the implicated drug was tirofiban, which was used in PCI, which causes drug-induced ITP. The drop in platelet count is very dramatic. Usually treated with rituximab and IVIG. So The thrombocytopenia can be a manifestation of rheumatological disease also. It's a female with platelet count, persistent low platelet count. She was planned for splenectomy from another hospital, came for second opinion from our side. The physical examination showed features of SLE. So SLE can, the thrombocytopenia, anemia, and leukopenia can be a manifestation of the clinical criteria of SLE. So always consider SLE, or collagen vascular disorder, as a cause of cytopenia. Another case of female with the dyspnea on exertion, she had hypertension, fetal edema, bilateral basal crabs. She had anemia with a reticulocytosis. Platelet count was 25,000 with high LDH. Creatinine was 5. Her facial expression showed scleroderma facies. Her fingertips showed gangrene and necrosis. So this is basically scleroderma renal crisis, which can present with MAHA with or without thrombocytopenia. So the take-home point in thrombocytopenia is always do a manual platelet count with a peripheral smear, and always check the platelet count with citrate sample. If the platelet count is more than 30,000, the bleeding manifestation unlikely to be due to thrombocytopenia. We have to find out other causes. Always look for the smear finding of large platelets and platelet clumps, which indicates adequate platelet count. Coming to the third part, pancytopenia, adequate history and physical examination is needed. We have to look for the duration of symptoms, the clinical history of the patient. You have to examine for the nodes and splenomegaly. So again, in the Coulter, we get differential based on the size and granularity of the cell. So if you get a monocytosis in a Coulter value, or if you get a lymphocyte predominant differential in the Coulter, it's always abnormal. You have to find out. We have to work up for. We have to look for a peripheral smear to check that. So when you see peripheral smear, these red flags should lead you to do a marrow. So if you have NRBC, or if you have blast, or if you have teardrop cells, that are red flags, we have to proceed with marrow. So next step is marrow. So clinician should clinician should have a proper marrow technique before shouting to the pathologist. So we should have ideal good quality aspirate, good quality biopsy. Always take peripheral smear along with the aspirate, and we have to collect additional DT and heparin tubes to maintain to do additional testing. So the aspirate, the ideal technique for aspirate is you have to instill enough amount of local anesthetics to the periosteum and the skin and periosteum. You can use up to 20 to 30 ml for an adult. We can use LP needle to infiltrate the periosteum. So you can use the Jamshidi needle. After the initial 0.5 to 1 ml is the marrow content. Remaining is all blood. So when you remove the initial 0.5 to 1 ml, you spread it into a slanting slide, allow the blood to run down, and then make the slides from the upper part of the slide where there is marrow particle. Ideally, we should visualize the marrow particle in the smear. And biopsy, we should have an ideal biopsy is around 2 centimeter. You need to get a biopsy around 2 centimeter. The importance here is when you pierce the cortex and subcortex, the both cortex and subcortex is hypocellular area, so it will be misleading. So we need to have an adequate proper biopsy. And most of the time, the cause of dry tap is faulty technique. So you should ideally try to do one more biopsy from one more site. If the second site also is dry tap, then the other causes are like fibrosis due to myeloperipheral neoplasm, or secondary causes of fibrosis, or compact marrow, etc. So pancytopenia we can differentiate based on impaired production because of marrow failure disorders or marrow infiltration disorder, or you have peripheral destruction due to different peripheral destruction of the cell lines due to splenic secretion, or we can have both features like HLH and PNH. So in impaired production, usually the absolute reticulocyte count will be low and they'll be having high MCV. In peripheral destruction, your absolute reticulocyte count will be normal. So some case examples, this is a rheumatoid arthritis patient on methotrexate and leflunomide, patient present with progressive pancytopenia. There was no improvement in stopping, even with stopping leflunomide and methotrexate. She had mild splenomegaly. The differential showed normocytic anemia, low WBC count with lymphocyte predominant differential, platelet count was low, LDH showed mild elevation, smear showed large granular lymphocyte. This is large granular leukemia associated with rheumatoid arthritis. Now, next is the common constellation which we see in cirrhosis patient with splenomegaly and portal hypertension present with pancytopenia, and they will have differential, they'll have anemia, they'll have normocytic anemia, they'll have neutrophil predominant differential, that is important, and they'll have mild thrombocytopenia, mild to moderate thrombocytopenia. Other dimension will be normal. So when you do a marrow will be showing normocellular marrow, no abnormal cells. So the points towards hypersplenism is history of cirrhosis 1, presence of splenomegaly, and neutrophil predominant differential in the peripheral smear, and not severe thrombocytopenia, and no severe anemia requiring transfusion. These points point towards hypersplenism. Another case of male patient with history of gastritis on PPI. On and off PPI. He also have diet preferences, avoids meat, not taking meat regularly. He had icterus and stop space was dull. His CBC showed pancytopenia, hemoglobin of 7, MC was high, retic was very low. Differential showed neutrophil predominant leukopenia and thrombocytopenia. LDH was disproportionately high, very high, more than 4,500. The differential showed LFT showed intrabilirubemia. So here, the hyperproliferative anemia with high MCV and leukopenia and low platelet count proceeded with the peripheral smear. Peripheral smear showed signs of B12 deficiency like macrocytosis, macroovalocytes, and hyperspectral neutrophil. So it's a vitamin B12 deficiency. The clue for vitamin B12 deficiency will be patient will be looking like hemolytic anemia, but the reticulocyte production retic will be very low, and the LDH will be spuriously elevated. So I'll do one more case of paraproteinemia here, and I will stop. It's a 60-year-old male with diabetic kidney disease with stable creatinine for around for last few years. Suddenly there is a deterioration of renal function with decreased urine output. Here the hemogram showed anemia and other differences were normal. Creat very highly elevated. LFT showed albumin of low albumin. Globulin was low. No AG reversal. There were no M-band. M-band was negative. And X-ray screen there were no retic lesion. Here the suspicion of myeloma is high, so we should do a light chain quantification also, serum-free light chain assay also. So in light chain myeloma, you may not get a monoclonal protein, you may not get an AG reversal. Usually your albumin will be very low. So light chain myeloma should also be a consideration when you suspect acute kidney injury, even in a patient with pre-existing kidney disease. So thank you.
Thank you, Dr. Siraj Vasudevan, for the wonderful case-based discussion, which is actually commonly we encounter in our daily practice. That is a wonderful talk, and thank you for your wonderful presentations. This session is open for a discussion. Any doubt regarding this can be asked. And first, I will initiate with one question, because we come across tropical fever and thrombocytopenia. We were actually monitoring the platelet, both in the cell count, this one automated as well as the manual also. So when to transfuse platelet transfusion, when to transfuse, that what level? We wait up to 10,000, what you have mentioned like this. So what is a cutoff point, and how to approach this problem we daily encounter it?
So in the ideal indication will be a bleeding patient with platelet count less than 10,000 in manual count should be transfused with platelets. If there is no bleeding, if there is no fever, we can wait if there is no bleeding. If there is fever, the target should be 20,000.
Any questions from the crowd?
A nice talk. Thank you so much. Now the case number 3, there was a dark urine. No?
Yes, sir.
That mediastinal lymph nodes. Was it hemoglobinuria?
Sir, if there is in the presence of mixed autoimmune hemolytic anemia, there can be a complement-mediated intravascular hemolysis also. There can be an extravascular hemolysis also. So they can have present with hemoglobinuria and dark urine.
That is responsible for it. Number 1, what is the best test for iron deficiency? Best test for iron deficiency.
So in our setting, it will be transferrin saturation along with ferritin, sir.
Yeah, that's free soluble transferrin receptor. By ferritin ratio, more than 2. Is it useful? Are you practicing it?
We are not practicing that.
Practicing it.
It is ideal test actually.
Is it available?
Not sure about that.
No.
So, thank you for the nice presentation. Regarding the thrombocytopenia, apart from the drug history, because of the high prevalence of H. pylori, you have to definitely look for the H. pylori. That's a very important suggestion I want to.
Yeah, one thing. We are getting a lot of iron deficiency in very wealthy people who take PPI
Yes, sir.
continuously. And what is your experience regarding the PPI use and iron deficiency anemia?
So it's decreasing gastric acid is a problem. It is we need a gastric pH for iron absorption. So acrohydria or decreased gastric acid production will be a cause for iron deficiency anemia in the long run. And it is a cause for megaloblastic anemia also in the long run.
Do you give vitamin C always with iron?
No, sir. No.
Now, yesterday I read an article, overnight fasting, iron with vitamin C, and 3 hours after only you give even coffee or break.
Yes, there is a recent RCT from Switzerland, so where they found that once daily iron dose of 60 milligram elemental iron in an empty stomach is enough for an iron deficiency correction. If the patient is not tolerating that once daily iron like this, we can even give alternate day iron. So if you increase the frequency of iron tablet, whenever you give iron, there will be hepcidin will be increased in the body, and the hepcidin will prevent further iron absorption from the intestine. So even if you give BD dose, the second dose is not going to get absorbed from your body. So ideal timing of iron deficiency correction will be once a day, and if the patient is not tolerating, once in 2 days or once in alternate day. And we can add, as you sir said, vitamin C also to increase absorptions.
I usually give alternate day.
Yes, sir.
Because 2017 there is an NEJM article which
Yes,
said
same.
because the hepcidin mechanism, there is an inhibition if you give daily.
Yes,
So alternate day I am giving.
And
That's accepted.
One Indian RCT also there, they showed that alternate day is enough, adequate for iron deficiency correction, more tolerable to the patient.
Yeah, yeah, yeah.
Thank you, sir. I'd like to invite
so much.
Dr. Philip Finney, Head of the Department Endocrinology, Believers Church Medical College Hospital, to felicitate the speaker and the moderators. Thank you, sir. It's a gentle reminder to put your mobile phones on silent mode, and a subtle note to the speakers that there'll be a reminder bell exactly 20 minutes into the talk. Our next speaker is an eminent professor of medical oncology, a specialist with an impressive track record in the field, Dr. Srijit G. Nair, currently the Professor, Medical Oncology, Regional Cancer Center, Trivandrum. I extend a warm welcome to our esteemed speaker, Dr. Srijit G. Nair, to share his insights on enhancing care for patients with hematological cancers in Kerala, the Regional Cancer Center experience. I also invite the moderators for the session, Dr. Tommy Phillip, Principal, Pushpagiri Institute of Medical Sciences, and Dr. S.K. Matthew, Professor of Medicine, Believers Church Medical College Hospital.
That's just fine. Good morning, ladies and gentlemen. I am from the Regional Cancer Center, Trivandrum.
Good morning. Just one word. Good morning. Good morning to all of you.
I understand this is a very, very important, memorable day for the Believers Church Medical College Hospital, celebrating the 10th Foundation Day. So on this very memorable day, I extend all my regards and greetings from Pushtagiri Medical College. I'm very happy that a very relevant area of medicine is selected to celebrate this event. And I thank Dr. Chepsi and Dr. Boni and team for inviting me to chair this session. Now the topic for this session is enhancing care of patients with hematological cancers by Dr. Srijit Nair. I remember those old days when I was a practicing intern or a PG in Kottayam Medical College regarding the hematological cancers at that time. Mainly the physicians were dealing. I remember 3 drugs which were used at that time: melphalan for myeloma, chlorambucil for CLL, and busulfan for CML. So I remember the acute leukemias being also treated by some of professors. I remember our Professor K.P. Paulusar, who used to treat acute myeloid leukemia with cytosine arabinoside. Now, over the years, the practice of cancer has evolved rapidly, I think, in the 30, 40 years. And the Regional Cancer Center also came at that time, I think, in 1981. And there was a whole lot of burden for the Regional Cancer Center. And subsequently, all the oncology centers evolved over the years. But still, I think the services for hematological malignancies, we cannot cater for all the patients. And I think we have got a very eminent speaker, Dr. Srijit, to elaborate on this. Especially, he has got tons of experience working in RCC. I'm sure that he will be able to share with us his experience and how we can enhance the treatment of patients with hematological cancers. Over to Dr. Srijit.
Good morning, ladies and gentlemen. I started my MPBS in 1980. And 1 year later, Professor M. Krishnan Nair, this gentleman, bought out the concept of the Comprehensive Cancer Center in Trivandrum, in a small room in a dilapidated, most dilapidated, because at the time the thought was people with cancer never needed anything. And from there we have come up. And this was the aim. It was established in 81. It was basically a government, Kerala and Indian government had put in an lot of money. It was a comprehensive center. It was catering to people of Kerala, Tamil Nadu and Karnataka. Now this was the vision, to emerge as a global leader in cancer control. Mind you, it's cancer control and not treatment, because that was the idea of Professor M. Krishnan Nair, who decided that it's better to control the disease, find out cancers early and treat them, rather than pick them up very late, bring in an obscene number of syndromes and start all sorts of nonsense. So that was why cancer control took a very important part. Sadly, hematological malignancies do not fall into that ambit. So hence, this was the mission: quality of care at affordable cost. You have to create a cancer awareness, train manpower, outreach programs, focus cancer research and cancer control activities throughout the state. This is our load. Total number of cases we have seen up for from 1982 to 2021 is 3,48,078. Initially, Regional Cancer Center was decided to cater to around about 5,000 cases. Now it has gone up to 16 to 17,000, and 12% of which are hematological malignancies. This is the relative proportion of patients with hematological cancers. From 1,083, it has gone up to 8,724 in the years 17 and 21. We're just compiling the data for 23, and it's still going to be higher. There was a small dip on account of the COVID pandemic. Other than that, the numbers are rising. Now, somebody could always ask us, is it the fact that all the cancers are rising like anything? The answer is no. It is a pattern of referral. Probably in a couple of years to come, this is going to drop, because there are plenty of other centers, well-trained hematologists who can take up a part load and bring down the strain for us. This is my hematology load. But before I started my career in hematology, in oncology in 1991. It's almost 30 years. I'd like to tell you a couple of stories. Now, for Hodgkin's lymphoma, how many of you oncologists sitting in the group have used any drug other than ABVD? I think yes. He might have used mustine hydrochloride, a gas. One of the most deadliest stuff you can ever dream of. It literally burns the marrow like that. I know as a postgraduate student, when we use mustine hydrochloride for Hodgkin's lymphoma, day 8 chemotherapy we are rarely able to give. And for the second and third chemotherapy, the pancytopenia and neutropenic sepsis is simply beyond. It blows you over the roof. And ultimately, there's a prolonged myelosuppression and death. This suddenly changed and people started using COPP. I've seen that. Then it became COPP, ABV regimens, and ultimately Bonadona's ABVD, which changed the landscape of the management of Hodgkin's lymphoma. There was something more. In patients who had presented supradiaphragmatic disease, there was something known as a staging laparotomy. I think the only person who would have done this, Vikram. You do a chest X-ray. CTs were not that freely available. An ultrasound scan of the abdomen, which up to a number of times may not work properly. So once you have a disease that is confined to the supradiaphragmatic region, the idea you give what is known as a mantle field radiotherapy. But you give a mantle field radiotherapy only in those patients for whom you have to be absolutely sure there is no infradiaphragmatic disease. How do you do that? All patients go into the theater, the surgeon does a laparotomy, he pulls out the spleen, sections it into 1 centimeter pieces, makes sure there's nothing up there, then all sorts of injections, and ultimately you start him with that. Once the CTs came, the scenario changed. PET sharpened the findings further. And without a PET now, I don't think anybody does chemotherapy for Hodgkin's. The next one is multiple myeloma. This I'll wait for the last set. The second one, most important, which I will tell you, is chronic myeloid leukemia. I think when we were doing post-graduation at the same time. It was Myelran. It's a deadly disease, something which you use for a transplant to finish off the marrow. After some time, you have a sequence. Patients with chronic myeloid leukemia are diagnosed. You put them on Myelran. Myelran fails. Count started increasing. You put in hydroxyurea, and ultimately patients start with pain in the left side of his abdomen, nothing but the spleen increasing. One fine morning it becomes very painful, start morphine, local RT, third day he's dead. The scenario changed. The next part of it was the administration of interferon plus cytosine arabinoside. That made a difference. The remission rates, very few people attain molecular response, but still, at some point of time, they had some sort of a response. But the most important fact was that there was at least a bunch of people, albeit very small, who could come under the ambit of a cure. The cure in the sense that the percentages are very low, maybe less than 5%. But it was the first time somebody was able to demonstrate that chronic myeloid leukemias. Then came Brian Ducker's magic bullet. My longest survivor is 25 years and no transplants, unless they go in for blast crisis. But suddenly, we are seeing a new phenomena in the offing, intolerance to TKIs. Patients present with early thrombocytopenia. All the jugglery which we could do to come to a diagnosis is off. And suddenly you find that you are forced to switch on to a second or a third generation TKIs. Next is leukemias. Way back in 1980s, 81, 82, I have seen case sheets where people were treated with vincristine steroids and then nobody knew what to do. And ultimately they used to give monthly vincristine, then it's twice monthly vincristine. But surprisingly, there were survivors. In my hematology unit, we have got an interest in osteogenic sarcomas also. So in 86, when you go for the final examination, you tell the surgeon, that you have to tell the answer, what is this treatment of osteovenous sarcoma? It stands for Kate's regimen. In 90s, when I went for my DM examination, I opened my mouth and tell him it's Stanford Kate's regimen. My chapter is closed. He'll ask me, go. Things have changed, and I've seen the change. Now, this is the average age of diagnosis. Surprisingly, we find that the 40s to the 50s are both the probable ages for leukemias, lymphomas. For multiple myelomas, it's slightly on the higher side. Now, the age groups, the ranges, 65 plus, maybe it comes to a bit low, but it's the 40s and 50s, they are the ideal. But this is what we have seen there. What is the relative proportion of patients with leukemia? 82 to 2021, 4,046 cases into 17 to 21, numbering about more than 500 per year. That's a big number. And with my very little resources at hand and the lack of space, we have to find some sort of a jugglery with beds. And you know what we do now? Acute myeloid leukemia is only inductions go in for IP admissions. For high-dose Arasi, we know it's very risky, but still we all give them chemotherapy as OP, and once they start dropping their counts, they are pushed in. We don't have any other resources. Even mini beams are being done as outside OPs because we do not know. And moreover, the IP costs are quite high. Now, these are my issues in the management of leukemias. The first is lack of space. The total number of beds I have for leukemias is might be 40. I have tripled the number of that in various states. Number two, logistics. Most of the people who come to my hospital are on welfare schemes. So the big question is, I have to modulate my finances such a way that it fits into my packet. The moment you just goes off, that's the end of it. I have to find other ways by which I have to support him, or else the patient will die. The third, neutropenic sepsis. As much as possible, that is what is going to eat into my resources. I think it should be the same for you too. The microbiology. Even though we have the state-of-the-art microbiology facility, everything is expensive. And last but not the least, how do you manage relapses? This is a situation probably you are also going to face once your hematology department starts getting busy. You cannot waste your hard-earned resources for relapses. In those patients whom you have a definite plan, like going in for a transplant, you probably will have to mobilize the resources for that. Otherwise, you have no options but to mark him for palliation. This is the proportion of lymphomas. The same figures are almost the same, but these are my problems. Obtain number of times patients are referred to us without a proper histopath. No proper staging is done. And there is an indiscriminate use of steroids, which makes my life very miserable. Usually when I have a tissue that is sampled and given for review, I can have some sort of an answer within 24 to 48 hours. But once you give plenty of steroids, and some people won't even tell us that they are taking, the whole architecture of the lymph node, peripheral smear, everything is doomed. There will be a delay. And the delay will keep on and on and on. And by the time when I start treatment, he will have some other problem in addition to the one with which he came. So as much as possible, please don't give him steroids unless it is absolutely necessary. And if anybody is planning to refer him, please mention it. FNAC and true cuts for lymphoma. No. We need a full intact lymph node. If you find that your hospital or your setup cannot give me that, please don't do a biopsy. You send it to us. Then there's something which people have been, this is monoclonal B lymphocytes. The total number of clonal B lymphocytes is less than 5,000. People get very alarmed and start treatment. No, there's no indication for any treatment. And inadequate antibiotics. Most of the patients who come to you with leukemia sometimes have infection. Some people very rarely take even a for cultures, they will put in a concoction of various antibiotics, and by the time they come to me, it becomes a mess. And last but not the least, timely referral. That is the crux of the game. Now, this is multiple myeloma. You all know it's an elderly. This is my problem. There is an entity known as monoclonal gammopathy of unknown significance. Somebody who is above the age of 60 being evaluated for another disorder, suddenly you find that you've got a paraprotein there. Don't have to treat him. Just doing a complete workup, and if he still happens to be a low risk MGS, leave him alone. 2, some people do a marrow or even a peripheral smear. You find some macking of plasma cells in the peripheral smear of the marrow, dump it as plasmacytosis, they start treatment for myeloma. At least you tell the patient that you need to be treated for myeloma. No, it's not necessary. Unless you have the full criteria, which has to be fulfilled, that puts it either with a smoldering, whether it's an MGUS or it's a full-blown myeloma. Only then the full-blown myelomas need treatment according to your CRAB criteria. Now, the next problem is a delay in surgery. If you have got a vertebral compression, please fix it. Take a biopsy, make sure that he does not have paraplegia, and then send him to us. Then physiotherapy, there's an access delay, we know that. And pain and supportive care. This is the something which is going to add to the cost of your treatment. What we have done is, we mark these patients quite early and send them to the local hospital, and then you will have only consultation. We don't ask the patient to come down. Now, this is about a transfer. We have a small transplant unit. We started off in 2002. 2 private rooms. All the consultants will go there in the evening, clean up the whole room, take surveillance cultures, lock it, clean it up, and then you start our transplants. We start off in 2007. We had a lot of bouquets. Not a lot of big bats first, then bouquets. Some people are asking me, why do you want a transplant? It's going to be expensive. So with this amount which you're going to spend, maybe 2.5 to 3 less, you could treat one pediatric ALL. So we took almost 5 years to convince those people that things are different. So total number of autos which we have done is 436, 307 for myelomas, lymphomas, and germ cell tumors, and 47 allos. And I would like to thank Vikram because he has just helped me on many funny situations. Thank you, Vikram. Now, the question is why we cannot do anything more regarding this. Here, the biggest problems in logistics. We get around about 8 lakhs from Prime Minister's Relief Fund, another 2 lakhs from CM's Relief Fund, and that's it. Putting a patient inside for an allo, you can pull him out on day 28, but all the drama happens after that. So that is a primary concern. If you're planning something, please make allowances for that. That is where you're going to flounder, because the cost can touch any value. Now the transplant issues we have only a 4-bed transplant unit, and we have got around about 40 to 45 patients waiting. Most of the patients, I think you should be having the same problem, isn't it? Yeah. And most of the patients relapse during that time. And we do not know what to do. So I think we should have some sort of a consultancy or a cooperative services whereby these patients can be treated to. There are other patients and places where they're doing a lot of transplants. I think somebody has to talk to the government and get it done. Because otherwise we'll be simply putting all these patients who otherwise would have been survived in ambit of relapse. And a huge waiting list. Now these are the problems. One is logistics. From your side, early referral. And novel drugs. They're very expensive. And I do not have much experience in that. And last but not the least, when to switch to palliation. That is something which you can take in your center. But it will be different from us, because we are a government center and the government expects us to treat everyone. Now my last slide, how do we wriggle this out? Cooperative strategies, we need consensus, early referral, we have to make the administrators allocate more funds for us, and only then we will be able to do something regarding research. Anyway, thank you for your patient attention. Any questions I can take?
Thank you, Dr. Srijit, for your very clear and authoritative presentation on the hematological malignancies, and you took us along the difficult pathways and difficult scenarios you underwent in developing the care and management. I really appreciate you for your hard work, and you represent the RCC about the care and you are giving to the patients. All the time we refer, and many of the hospitals refer to you, and I would say that you are giving an excellent care for all our people. And you also mentioned your difficulties and also your problems, and taught us something like the excess use of steroids, timely referral, etc. I find it is very important that we get expert consultation and timely referral for proper care. Now I think we have the cancer committees in district levels, and we are trying to register, care and prevent, and cancer being one of the frontliners in the non-communicable disease. Thank you, Dr. Sujit, and I invite the audience to have your questions for the a pioneer in care of hematological malignancies.
Okay. And something more, COVID has also taught us something. We decided to divest most of the primary chemotherapy to tertiary hospitals and also primary health centers, and they are now doing it very good work, so that whenever we had whenever we delegate our responsibilities to other people in the management of minor chemotherapy, the physicians there also became very confident, and now a bulk of our work is done with the primary health centers, PHCs and major hospitals. So that is something which COVID has taught us. Okay.
Do you think that leukemias are coming down in Kerala?
I don't think so. The pattern of referral numbers are increasing, and what I feel is that with our resources we have to do some sort of a jugglery. That's the only way. I think Vikram is the best person to talk about that in the national sector. Okay.
Thank you, sir.
Thank you.
Thank you, sir. I'd like to invite Dr. Girija Mohan, Professor, Department of Pediatrics, Principal, Believers Church Medical College Hospital, to felicitate the speaker and the moderators.
Thank you, ma'am. Thank you, Srijit sir, for accepting our invitation. It is very difficult to get sir to come out of RCC for talks like this. Thank you so much for gracing this occasion. Now, I would like to invite all the dignitaries, the chairpersons and the speakers to kindly come and inaugurate the session formally by the lighting of the lamp. May I invite all the speakers and the chairpersons, please. May I request everybody to be seated, please? Thank you all for taking time out to attend this important milestone in the journey of our institute. It's a proud moment for all of us. And today, we also have additional luminaries and a real rock star in hematology, my mentor and teacher, to many of us who are seated here. I don't even have the guts to go near him and give him the talk about him. So it is a great honor, sir, that you have accepted our invitation to come and grace us with your presence. So originating from the Latin term Decennalia, which refers to a 10-year anniversary, and Excellencia, that underscores the pursuit of excellence, we have this oration that signifies a decade of progress, growth, and transformation in the chosen field. So our rock star for today, Professor Dr. Vikram Matthews, has been a luminary in the field of hematology as such, transplants also, but special mention to excellent work sitting in India, which is a beacon of hope to all of us who practice here that things can be done. He has many discoveries to his name, but beyond that, he has trained many hematologists who now, many of us practice in different corners of India, trying our best to follow the example. So we have nobody more deserving for this oration than Sir himself, which also parallels the growth of our institute, 10 years of progress in trying to transform healthcare here. This oration features Sir, who has played a pivotal role in shaping the field of leukemia over the past decade. Now, I would request Sijo Achin and Dr. George Chandi to kindly honor Sir with the Ponnada. Thank you, sir. Just like Dr. Vikram has been pivotal for many of us, I would now invite another transformational figure, Professor Dr. George Chandi, our director, who has touched and continues to touch many of us, shaping our careers, shaping patients' lives, to kindly introduce the orator for the day.
Thank you, Chepsi. It is our privilege to award the citation for Decennalia Excellencia oration to Professor Dr. Vikram Matthews, Director, Christian Medical College, Vellore, on this day, September the 1st, 2023, as we celebrate the 10th Foundation Day of Believers Church Medical College Hospital. Professor Dr. Vikram Matthews, physician, scientist, erudite scholar, leader extraordinaire. He is being awarded this citation for his global leadership in the field of leukemia, especially for the path-breaking work done in acute promyelocytic leukemia, and in recognition of his exceptional achievements in clinical hematology and for being a beacon of knowledge and innovation. Dr. Vikram Matthews did his undergraduate and postgraduate studies at the Christian Medical College, Vellore, where he won just about every gold medal and prize that was on offer, and was our best outgoing student, both undergraduate and postgraduate days. Went on to do his DM in clinical hematology, one of the first few people that Maman Chandi trained. During his tenure, after he joined Christian Medical College as a faculty member, he went as a postdoctoral fellow at the stem cell biology section of the Department of Internal Medicine, Washington University, St. Louis. At that time, Dr. Matthews acquired invaluable insights into stem cell and leukemia biology. His subsequent role as a bone marrow transplant fellow at the Bone Marrow Transplant Unit and the Leukemia Unit of Washington University further honed his expertise in the field. He returned to the Christian Medical College, Vellore, where his teaching acumen and passion for research were so evident, with his diverse interests spanning from acute myeloid leukemia to the evaluation of mechanisms of resistance to arsenic trioxide, have resulted in numerous publications, including 144 manuscripts in major journals and 5 textbook chapters. Dr. Matthews' remarkable achievements have been recognized with prestigious awards, including the Investigator Award from the Bayer Hemophilia Awards Program, the Best Oral Presentation Award at the Asia Pacific Bone Marrow Transplant Meeting in Phuket, the DBT Welcome India Alliance Senior Research Fellowship Award. As a reviewer for esteemed journals, Blood and Leukemia, the Indian Journal of Hematology Transfusion, the Indian Journal of Medical Research, Dr. Matthews continues to contribute to the advancement of medical literature. His presence as an invited faculty in most international and national conferences reflects his status as a sought-after expert in the field. For me personally, it was a day of great excitement when the national committee that chooses the new director chose to install Professor Dr. Vikram Matthews as our director on the 23rd of September 2023. He starts his day at 6 a.m. in the transplant ward and is there till about 8 o'clock. I've been astonished at the way he carries himself and manages his research unit, a lot of travel because CMC gives a lot of emphasis for smaller hospitals, mission hospitals, and I think he's already gone 5 times to mission hospitals in this short span of 1 year. In recognition of this exceptional journey and remarkable achievements, a real role model for the medical fraternity, I am happy and proud to invite Professor Dr. Vikram Matthews to deliver the distinguished Decennalia Excellencia oration. Shall we put our hands together and welcome Dr. Vikram Matthews.
Thank you so much. Yeah. Go back. Where's the pointer? Where is the pointer? Or does it work on the... No, it won't work on the screen. I think it's okay, doesn't matter. Don't worry. Is there a connection? Yeah.
Good morning, everybody. Thank you so much for inviting me, Sir, Dr. Chandy, and the management. It's really a privilege and an honor to be here. Over the next 45 minutes, I know there's a wide range of audience with various specialties, students at different levels of training. What I thought I'll talk about is medical care, cost effectiveness, and excellence. I think this is particularly relevant to our country, especially in terms of the challenges that we face in many of the areas in treating patients. So my talk is going to be broadly along these lines. I'm going to talk about low cost effective care and high-end therapy. Is this an oxymoron? Can this actually happen, or is this something that is just words we use and it really doesn't matter? What is needed to achieve that? And I'll talk about some of my experience in certain areas. It's a little varied areas, and I can only talk about hematology. My whole life I've been trained in hematology, and I'm sure many of this will apply to each of your specialties as you all innovate and do things differently. And at times wonder, are you doing the right thing? So I'll talk a little bit about the arsenic story, and I try to touch on translational research there. I'll talk a little bit about transplants in thalassemia, and the point that I'm trying to bring home with that story is the importance of your own data and not just published data. I'll talk a little bit about CAR T-cell journey, and I'll talk about, and the purpose of that is to talk a little bit about role of innovation and role of cost effectiveness. And finally, I'm going to touch on something that's been recently quite dear to me, is our outreach hospitals, a world way beyond tertiary and quaternary cares, which is another universe, which many of us should explore, and there's an incredible need out there. So let's start with low cost and excellence. Often, this is the paradigms that we are given. On the one hand, we have cutting edge research, high quality standards, very high standards of safety. Unfortunately, they often go hand in hand with inaccessible, irrelevant for the vast majority, capitalistic, for-profit only model. And on the other hand is poor quality research, poor and dubious quality standards, poor safety and risk for patients, but freely accessible to everybody, completely socialistic. Surely we can get it right somewhere in the middle of this. So there is an opportunity for us, and let's see where we can go with some of the stories that I have to tell you going forward. Now, this is the vision and mission of Christian Medical College. The Christian Medical College Vellore seeks to be a witness to the healing ministry of Christ through excellence in education, service, and research. And I want to stress on the word excellence, and I want to highlight the importance of each of these three elements in bringing high-end therapy and making it cost-effective: education, service, and research. And I talk the importance of a lifetime of commitment. I don't use the word intentionally a lifetime of service, because often the word service comes with the concept of suffering and giving up something, and that's not true. It's a lifetime of commitment, it's a lifetime of joy, it's a lifetime of constantly being challenged and being excited and leading a life that is actually fulfilling. So let me tell you the arsenic story to take you to some of the challenges we had and how we've evolved. So this is a body of work that was done by none other than Dr. Chepsi. He's somewhere here in the audience when he was a student with me. This actually gained quite a bit of mileage in the community at that time. This is the story of patients diagnosed with acute myeloid leukemia in the country and who are coming to our center. Nobody actually looks at their own data rigorously and actually question. You either remember the case that was fantastic and cured with his one-line therapy, or you remember the fellows who did terribly. But to get a broad perspective, you need to systematically, prospectively analyze data. And that's what Chepsi did as part of his thesis. And we all knew AML is one of the most expensive diseases to treat. Very few people can access it. The cost of therapy, Dr. Srijit already alluded to, neutropenia, sepsis, ICU. It's not the individual drugs. It's all the management of all the complications that the therapy results in that is difficult to manage. In India, we have a high incidence of multi-drug resistance organisms. Not sure what the incidence is over here. In AML, you give high-dose chemotherapy, the guy gets a multi-drug resistance infection, you're looking at death in 6 to 12 hours. From well to dead, It's a very rapid, and so it's challenging. You can't intensify chemotherapy as you would want to in many of these patients. And what was depressing was that in reality, we were actually offering curative therapy in only 29 to 30% of our patients. The rest of the patients could not afford therapy. Even though we are a non-profit, it's impossible to take on this load of patients and give free treatment to everybody. And so we would refer them. And CHEPSI actually followed up almost 70% of these patients and found that in reality, these people don't get any definitive therapy. And this is what is happening in the country in acute myeloid leukemia. The vast majority, as part of the Hematology Cancer Consortium, looking at multiple centers, it's a setup that I've, with Dr. Manju Senga and TMH, we set up across multiple tertiary centers across the country. It's exactly the same phenomena. A small fraction of AML patients are actually treated. In the West, people would be appalled if you said you send a 20-year-old home on palliation, because these are highly curable malignancies. So nobody talks about it. We had patients with APML. Now, acute promyelocytic leukemia, I'm not going to get into the technical details. These are patients, it's a subset of AML, about 10-15% of them, which are very different in biology and phenomena. But for the most part, in the early 70s and 80s, we treated them just like AML. And they had the worst outcome of all AMLs till a drug called all-trans retinoic acid was introduced, which is essentially vitamin A, which differentiates the blasts and makes them. Basically, in leukemia, you have these blasts that are arrested at a blast stage, and they cannot differentiate into neutrophils, into the normal myeloid component. They get arrested, and then they proliferate. And ATRA would bring about differentiation of these blasts into neutrophils, and then the natural process of apoptosis would happen. We had patients in that era who would receive either the AML-type chemotherapy or even ATRA-based therapy, who would relapse, who would go away. We would essentially send them on palliation and say, well, that's all we can do for you. And they would come back 6 months later looking absolutely well. And what we realized as a pattern is many of these people were going to Dehradun to a person called Balavendu Vaidyo, and he was giving a treatment, a native medicine, which we knew was rich in arsenic. And these people came back completely cured. ECOG performance score 0, absolutely well, like you and me. The problem was they were giving this continuously, and many of these patients ended up with second cancers. At the same time, we realized the Chinese had actually published a data on relapsed APML where they had given arsenic trioxide. So in 1998, arsenic trioxide has a very colorful history for the students in this audience. It's a drug that's the oldest drug in the pharmacopoeia. It's been used for all kinds of things, from even improving young ladies' skin tone in the early 15th, 16th century, to treatment of CML, to treatment of syphilis, all kinds of things. It was also called the best way, it was also called the inheritance powder, because it was tasteless, odorless. And so if you had a rich aunt or uncle you wanted to bump off, you keep giving him arsenic in his food. So there are stories of arsenic in old days. So it's a fascinating molecule in many ways, It's incredibly cheap. It's like salt. You can buy salt, you can buy arsenic trioxide in the market. And arsenic trioxide works in APML, unlike other cancers. It's a non-specific cellular toxin. When I say non-specific cellular toxin, what I mean is, if I give enough of it, it'll kill any cell. But in APML, and that goes for all drugs, by the way, including water. So it was Paracelsus who said long ago, any drug is a poison or beneficial. It all depends on the dose. So if you give anthracyclines every day for the rest of your life at very, very small doses, the guy will get cancer, while it may be able to treat AML at small dose. So there's pharmacological dosing and there's pathological dosing. Now in APML, at pharmacological dosing, it doesn't have any off-target side effects, but there is an oncoprotein called PML-RAR, which it actually polyubiquitinates for those who are technically inclined. It takes it to the proteasome and degrades that oncoprotein. When that oncoprotein is degraded, the promyelocyte no longer remains a malignant promyelocyte. It continues on its normal path of differentiation into myelocyte, metamyelocytes, neutrophils, the normal ontogeny of the myeloid pathway. And this is what we believed happens. And this is a picture just showing the degradation of the PML bodies when you give arsenic trioxide. So we initiated a trial in 1998. I intentionally put up the timelines for you to focus on the timelines. January 1998, we started a study in Vellore. It was part of my DM thesis, actually, where we actually manufactured arsenic trioxide in the pharmacy. We bought this drug, AAA grade was what it's called, and we actually manufactured 10 milligrams a vial, cost us about 20 rupees. That's about 50 cents in those days in translational costs. Each of those points that I'm saying has some relevance. it basically included all patients. It wasn't a very rigid inclusion-exclusion criteria because the objective was we were treating 10-15% of our patients. The rest of the patients are going home to die. And this was a therapy, this is a disease even in the West where 70 to 80% cure with ATRA and chemotherapy, which people could not afford. So we were saying we're going to at least treat these patients who cannot afford it. And these are pictures with permission. This is Sister Teresia Ma, who faithfully prepared the arsenic trioxide for me in the pharmacy. And this is the very first patient on 20th January 1998 who started treatment with arsenic trioxide. And a big thank you to Dr. Alice Kurula, who was the head of pharmacology service at that time and who was willing to actually go out of the way to do this for me. I'm not going to go to the technical details of this slide. There was a lot of information behind how this protocol was designed, the induction, the consolidation, the breaks, and the maintenance. But we went ahead and did this therapy, and we had actually astounding results. 60-70% of patients were cured, and people who presented very early with very low blood counts was an incredible cure rate. And so we had a lot of publications on this. We were very excited because here we now had a treatment which cost practically nothing. And there are many other elements of this treatment which were very good. It's not like a chemotherapy. After the initial induction, 1-2 weeks, the patients were well. The patient received the entire treatment as outpatient, no alopecia, no mucositis, no neutropenia. So it seemed pretty exciting to me. We had multiple studies done. And we had multiple publications addressing various issues related to arsenic trioxide, hepatotoxicity, what happens to other molecular patterns, and it was all good. But incredible criticism. So people who are not aware in the early 90s, 2000s, people would say, how can you do this? This is unethical. It is ethical to send 80% of people home to die, no problem. But how can you do something that's not validated? But we said, we've done this, we have done it systematically, we've done it to the best of our ability, we are conscious, we have no conflicts of interest, we have nothing but the patient's interest in mind. So it's not easy when you sometimes make innovations, you will get challenged. As long as you are honest and your integrity is high, you don't have to worry. We were treating these patients in the outpatient, as the picture shows you. They were not cardiac monitoring them. They were getting infusions in the OPD, and they would, after the initial induction, they would come to the OPD, get the injection, go, and come the next day. So every day the injections were given. And subsequently, we published our data in 2006. 1998, we started, and a little bit of attention. But the world was still not worried. Even in 2008, there was what's called the European Leukemia Net Guidelines, which all hematologists read very faithfully. And there, arsenic trioxide cannot be used. It is combination chemotherapy that must be used. And then in 2013, so it's very interesting to notice international dynamics in publication. So in 2013, when this randomized control came using no chemotherapy, only arsenic trioxide and ATRA, the people who wrote the 2008-2009 guidelines were already involved in this trial. That means they believed that there's potential in this, but they write the guidelines in such a way that it is a terrible thing to do. Anyway, this publication came out. I'm not going to go into the details again. Essentially, without chemotherapy, with an arsenic trioxide-based regimen, you could cure APML. It is today the standard of care in the world. And this is something that we started way back in 1998. And we have since moved on. We've published our combination data. And today, all the students, if there are any of my students here, will vouch for it. Any APML patient comes to CMC, almost certainly they will not be turned away because we have a therapy, and today with the combinations we use, we can achieve almost 90-95% cure rates in these patients with excellent long-term outcomes. What is much, much more fascinating, and especially for a medical audience to understand, is the entire pharmacological environment of this game of medicine. So this is a very detailed economic analysis we did of the arsenic trioxide we produced. Remember, after the first few years when we were manufacturing it, for medical legal issues, we had to transfer the manufacture out into industry. We couldn't continue to manufacture it. This is the reality. We really don't feel there's any difference in what we manufactured and what we transferred to Intas to manufacture. There is absolutely no difference, and there's no very complicated formulation that made a difference in the lives of people, etc. As I said, it was literally like buying salt. There was a little heat solubilization, heat-alkali solubilization that was required, stability studies that had to be done. All that could be done in-house. But we took it to the market, and when we took it to the market, from that 20 rupee cost that we were manufacturing at, it went to 400 to 450 rupees for 10 milligrams. Quite a bit expensive. They were giving it to CMC for a special rate of 200. But with that rate, we did a bottom-up cost analysis. This is a very detailed economic analysis. I'm not going to go through it. For those who understand economic analysis, health economic analysis, it's called a bottom-up cost drivers and the fund and the analysis of them. Every single element that goes into the treatment, including a Markov model of survival, death, etc., is factored in making this cost. And the net impact of this, without getting into too much of the technical details, because all this data is out there, is we treat 100% of our patients with APML today who come to CMC because of this protocol. That ATO that was 10 milligrams, 200 rupees to 450 rupees in India, the cost in the US is $450 to $600 for 10 milligrams. A patent was filed around 2004 odd by Memorial Sloan Kettering, because there was no patent. The Chinese and the Indians were using it, but we had no patent. They patented it, and the patent applies to Europe and whole of North America. And today, the paradox is arsenic trioxide-based therapy is the most expensive therapy in the West. And people are talking about access issues in the United States. In India, and for most parts of the developed world where the patent doesn't apply, it is the least expensive therapy. So when pharmaceutical industries come and tell you about all the hard work they did in bringing across drugs, a little bit of cynicism and skepticism is healthy to have. We continue to challenge many of the dogmas in this field, including statements like if a patient relapses after arsenic trioxide, the ELN current guidelines, the European Leukemia Net guidelines, will tell you that you should not use arsenic trioxide again. You should use intensive chemotherapy and then transplant. We said that makes no sense to us. Our own experience says reuse arsenic trioxide-based inductions, and we have a trial going on it, and then transplant them, and your survivals are still excellent. And these are some of the faces to the data. Over many years, children, adults treated, many of them have grown up. Fertility is preserved with this therapy, and it really is something that has benefited a vast majority of patients. So now moving on, how do we have the rest of AML where the problem still remains with this recurrent cytopenia, intensive chemotherapy. How can we get rid of that? So from the APML, I also run a lab and I'm involved in my own basic science research. We looked at arsenic trioxide resistance. So fundamentally, or very simply if you put it, a small subset of APML patients become resistant to arsenic trioxide. All other AML patients or AML cell lines are inherently resistant to arsenic trioxide. So the question is, how can we address it? This is a lovely picture from my lab, Dr. Nitya now, one of my students. This shows you U937 cell line and shows you that an AML cell line is rich in mitochondria. It's a little paradoxical because generally one believes in cancer that the Warburg's hypothesis holds. What's the Warburg's hypothesis? Very put simply, that cancer cells prefer glycolysis or anaerobic respiration versus aerobic or mitochondria-driven respiration. Very simply put, okay? And that's the basis for a large part for how your PET CT scan works. Your FDG glucose is taken up very rapidly in cancer cells compared to normal cells, and it lights up, okay? So we know now that in AML, this is not exactly true. Unlike many cancers, AML relies more on OXPHOS metabolism than on glycolysis. And this is actually turning out to be a potential vulnerability in cancer. Now, in AML, when we evaluated APML resistance, what we noted was in the resistance cell line, which is pretty cool because I have a cell line which has my name in it. It's called the NB4EV-ASR1. Eril Arsi is my student and me who created this cell line. And with this cell line, what we showed is arsenic trioxide is actually a glycolytic inhibitor. It inhibits glycolysis. And to some extent, that's how it may be working in APML, which unlike the rest of the AMLs, is very dependent on glycolysis. Arsenic trioxide, remember, also degrades that fundamental oncoprotein, but it also inhibits glycolysis. And APML, or arsenic trioxide sensitive APML, is very sensitive to inhibition of glycolysis, without going to the details we have demonstrated. So this graph or this cartoon kind of illustrates ATO sensitive, you could put it as APL or APL, shows that ATO inhibits glycolysis, and there is no other energy pathway even at these doses. In addition to that, it degrades the PML RA alpha and brings about apoptosis. But in ATO-resistant APL, even though if you put ATO, it inhibits glycolysis, it doesn't matter. Now, in AML, if you inhibit OXPHOS with a particular drug, for example, there's a non-specific molecule called FCCP. If you block the OXPHOS, what happens in AML happens in many other cancers. There's metabolic plasticity. You can switch. If one gets blocked, it will switch to glycolysis. If you block glycolysis, it will switch to OXPHOS. So what is the obvious option? Block both. But then what happens is you have fatal metabolic shutdown, and you will kill any cell, right? You'll kill all your cells because there's no source of real energy. So the concept was therapeutic drug repurposing. So as part of this, we screened, there's already data to look at drugs that can very specifically inhibit the OXPHOS pathway only in cancer cells and not in normal cells. And interestingly, many anti-malarial drugs come on the top of that list, okay? So what we did, working with Dr. Sanjeev Krishna in George University in UK, who had a library of this, and he's been doing a lot of work with these anti-malarials in cancer, we looked at combination of arsenic trioxide and anti-malarials and showed incredible synergy in treating AML cell lines. We've taken this work further into a mouse model and again showed benefit of this combination. So I would encourage you to watch the space very carefully, because a clinical trial will soon start with some of these combinations, and we hope we can replicate the APML story in the 85% of the remaining AMLs and end up with a therapy that is easy, low cost, and affordable for all our patients. And I put this picture up. This is an old picture because finally all this lab work needs to a lot of students, and you need to have a happy crowd. And I have two of my students I see over here. One is Sachin and the other is Ansu. Hi, Ansu and Sachin. And they were part of my team, and now they've moved on. So the laboratory is a great place. You get wonderful people who have great ideas. A lot of research actually comes from the enthusiasm of students and their ideas and concepts, which you have the privilege of guiding. Moving to the thalassemia story. Remember, this story is about trusting your own data, okay? So the principles of a transplant, I think most of us know. You have a donor, you have a patient who needs a transplant. You transplant diseases where there is a problem with the hematopoietic stem cell. The hematopoietic stem cell can be diseased as a germ from birth, like sickle cell or thalassemia, or it could be an acquired disorder, like a leukemia, which is essentially starts from the stem cell. And you have a healthy donor. Just like a kidney transplant or liver transplant, you're taking stem cells from the normal donor and putting it into the patient. Before you do that, you have to ablate the patient's marrow and his stem cells to get the new marrow in. And so this is what is done in thalassemia. At CMC, we do a large number of transplants. In 2022, almost 310 transplants. We are reaching the 5,000 mark in terms of transplants, and almost 30% of our patients who are transplanted are patients with thalassemia major. It's the only curative option that we know. Now comes the part that you need to focus a little bit on. The conventional classification relies on three factors. Is the liver palpable? Is there liver fibrosis on a biopsy? Any fibrosis, periportal fibrosis, extensive fibrosis, or inadequate iron chelation. And if we look at those parameters, we know what we call as those class 1 don't have any of them, class 3 have all of them, and class 2 is in between. So the class 1 and 2 do very well. The class 3 who have all this, that is a liver that's palpable, inadequate iron chelation prior to transplant, or have liver fibrosis on biopsy, do very badly. And that was the general trend, but even in the class 3, the survivals were about long-term was 50-60%. Now, in India, remember what people see in the West as treated thalassemia patients coming for transplant to what comes to you in India. You all don't see this problem here, but if you were to go to the north, you're going to see patients with thalassemia major, very poorly transfused, very poorly chelated. They will come to you at 14, 15, looking like a 4-year-old child. you know, with a massive liver, massive spleen. While if you go to the Middle East and you see a thalassemia child, you can't make out who's a thalassemia child and who's a normal child. They have no liver, they have no spleen, they're very well chelated, they're practically normal. So look at these two cases, both by the definition that I gave till now as class 3. But if I were to give this to any transplant physician, he will straight away tell me this patient 2 is doing bad, is going to do badly, just instinctively, without any details. And that's because one is 14, one has a liver size of 7. And we analyzed our data very systematically, put all our class 3 data, class 1, class 2, 3 data. And this is a publication that, again, I just want to highlight was way back in 2007, where we demonstrated that in our data set, if your age was more than 7 and your liver size was more than 5 centimeters, your overall survival was a appalling 25%. It is almost unethical to take a patient like this for transplant. Many places, not pointing fingers at anybody, how do we go about data, especially in India? Dr. Srijat just told you about the challenges of treating hematological malignancies in our country. And then we take our data and we want our data to look as good as Western clinical trial data. Even they don't get that kind of data in their real world. So often the reality, and this is the hard truth, is data is fudged. The denominators are moved around till your survival looks close to what is published and you feel, yeah, we're doing as good as them. In fact, that absolute honesty of your own data and recognition of your problem is absolutely critical if you want to actually move forward and make a progress. So we published this data and said, we have a subset of class 3, what we call the class 3 well or high risk, who will do very badly and who should not be transplanted. We then moved on, and this data was subsequently validated in 2010 by an international registry study in 179 patients, and further in 2019, a larger study, which CMC actually led as a multinational study as part of the International Bone Marrow Transplant Registry, showing essentially the same effects. And today, we are looking at how to improve the outcomes of the class 3 group of class 3 high-risk group of patients without, again, going into the details, just to illustrate the point. Identify a problem, then say, how am I going to change that problem? So what we did is we changed our conditioning regimen. We used a drug called triosulfan, and today our class 3 patients are doing actually very well. The top curves are the triosulfan curves, the bottom curves are the historical curves with the conventional busulfan was conditioning. So identifying the problem, saying there is a challenge and how can we face this challenge and how can we innovate to improve, I think that's absolutely key. And our long-term survival continues to increase. This is a picture, and I'd like the audience to participate in this. This is a father and a mother and 2 children. How many of you all think that boy is the guy who had a transplant? Put your hands up. 1. How many think the girl had a transplant? And the rest are in perfect homeostasis in their own locations with no answer, 95%, which is unfortunately very true of most medical schools. Anyway, so this is an illustration to just point to one fact. You cannot make out the difference between the donor and the patient 15, 20 years post-transplant. They look absolutely normal. So if you transplant them young and they come to you and you do a transplant, 10, 15 years later, it's really magic, you know? There are, of course, issues with sterility. There's a small risk of second cancers, all that. But consider to where they were going, this is actually a fantastic journey. And the final part in the thalassemia story, it's not important just to have a therapy that's curative, very expensive, can be accessed by only a few. Remember the talk of high excellence that I spoke about right in the beginning? So we work with the government, the Ministry of Health and Family Welfare, and Coal India, and a social corporate responsibility program, where patients from across the country get a fund for this and are transplanted. They get only 10 lakhs. The rest of it, we kind of raise some resources and subsidize and transplant. So today, patients from all over the country come and get this one-time curative therapy. That, I feel, is the importance of the question that Dr. Srijat just asked. Why do a transplant when you can use all this money? If we were to wait for the last diarrheal illness to be cured before we move on, we actually do a great disservice to this country, because there is so much that we can move, and each of these learning exercises adds another dimension, a layer of quality within your own system without knowing it. So we are challenging paradigms in transplant. Everybody talks of a myeloablative conditioning regimen. We use a reduced toxicity conditioning regimen, and we show that there's no difference in outcome. Large data, we trust our own data, immaterial of what is published, and we think that this makes a difference in terms of cost effectiveness to care. Moving on to really high-end technology, which is chimeric antigen receptor T-cell journey. So if you take patients with relapsed ALL or relapsed acute lymphoblastic leukemia, the lower curve is what happens to acute lymphoblastic leukemia patients who relapse. And after they relapse, doesn't matter what you do, including a transplant, their outcomes are abysmal. It's like 6-10% long-term survival. The same story exists to an extent in diffuse large B-cell lymphoma who relapse and come to you. The first time there's a high chance of cure, but if they do relapse, then the prognosis, especially within 1 year, patients who have already had rituximab in their first-line therapy, the outcomes are incredibly poor. So in this group of diseases, and subsequently now in many others, there's this concept of chimeric antigen receptor T cells. For students in the audience, the concept is very simple. You are essentially combining the humoral and the cellular immune systems. You're taking the receptor, the humoral antibody receptor, the light chain, which is particularly directed at a particular antigen on the cancer cell. In this case, it is CD19 in ALL and DLBCL, which is uniquely expressed on the surface of the cancer cells. So you take or create an antibody that will recognize that CD19 epitope, which is not present on any other cells in the body. You put it into a viral vector, which is essentially a HIV vector, which is gutted out, which cannot reproduce, and you put it into the T cell along with the elements of the T cell receptor. So what are the elements of the T cell receptor? Going back to your physiology days, all that was relevant that you learned in physiology and you quickly forgot. One is the co-stimulatory molecule, and the second is the T cell activation domain. So you put it in, and now you have a molecule that sticks outside the T cell, which is floating around. Any CD19 it binds to, it will immediately trigger a signal into the T cell through the activation domain and make the cell go alive. So how do T cells kill other cells? It's terrible. They're blind, deaf, and dumb, but they're absolutely ruthless. Okay, they secrete these substances called perforins. Perforins go out and punch holes into the cells that they attach to. And in addition to punching holes, just to ensure that death happens, they also secrete substances called granzymes that go through the pores and literally digest up the cell that they attack. Okay, so it's a terrible thing that's coming the way of cancer cells. But anyway, once you engineer these CAR T cells from the patient's own T cells, you take it out, you put this vector, which now the T cell has the CD19 receptor and the T cell activation domain. Now the recognition is independent of HLA. Doesn't matter the HLA pattern recognizes the epitope or not. As soon as this cell sees CD19, it's going to start activating and kill the cancer cell. Okay? So what are the problems with this? This is the first patient who got it. This is Emily Whitehead's story, and this is a picture she takes every year after she relapsed from ALL. And 2012, she was treated at CAR T cells, and she continues to take a picture every year. Really an amazing story for those who see everybody talks about chimeric antigen. It's one of those really breakthrough kind of technologies. What's the problem? This is the problem. We have a few molecules. It's all industry driven. The cost of one shot of CAR T cells is $500,000. So this takes you back to the paradigm of what we had in the beginning. Very high-end therapy, high excellence, fantastic quality, practically inaccessible to everybody. It's a little bit like your hand flexion and extension, It's fully flexed or it's fully extended is useless. So you have to have the ability to move around for it to be of any benefit. So what do? How do we get CAR T cells therapy to our country? So we've been this route before. As a country, as what we call the southern countries, the developing countries, we have gone through these challenges before. This is not the first time we're facing it. Remember the HIV, we tend to forget history. Remember the HIV epidemic, fantastic drugs cure, nobody could access it. Then what happened? We came up with generic drugs, huge criticisms, terrible quality, this. Yes, those problems are there, no doubt about it. But at the end of the day, India today supplies 92% of the drugs to the world for HIV, and we contribute to cure of majority of HIV patients in the world. So we've been there before. Take CML. Dr. Srijit already told you about the tyrosine kinase inhibitors. When they came out, unaffordable. Nobody could afford it. Generics came out in India, huge criticism, poor quality, this, that. Many of them, don't forget, is actually industry-sponsored write-ups. We today know that if there's any drug that made a difference, it is the generic molecules that made a difference in chronic myeloid leukemia. So cell and gene therapy is new. It's just the next challenge for us of how we are going to make this therapy available and accessible to all. So what do we need? We need increased research capacity. We need manufacturing of reagents, local manufacture of vectors, that is the viral molecule with the construct. We need to decentralize manufacturing, move it away from industry. Anything that stays stuck with industry, you're in trouble. Public and government-private partnerships, I'm happy to say all this is happening in the country to a large extent, except the manufacture of local reagents. TMH Mumbai and IIT Mumbai and TMH in Tata Medical Hospital in Mumbai have come together. They're really the leaders in this. They've produced an indigenous vector, and a really large trial is going on there. Hats off to them. The IIT Kanpur is developing a vector core. Origin, Intas, ImmunoAct, these are companies that are coming up with starting to produce CAR T cells in the country. So the cost is certainly going to come down. Our own experience has been in manufacturing CAR T cells within our center itself. Not been done before in a complete academic setup. Huge challenges. This took me 2.5 years of working with regulators to get this going. It's not something for the faint-hearted and not something that you can do without incredible perseverance and patience to deal with the regulators in this country. So we have a class 10,000 facility. We have all the elements, but it's just difficult. And so this is a publication that we've had. It's open access. You can look at. I'm not going to go into the technical details of the actual methodology. Safe to say that we can manufacture CAR T cells in-house, okay? And the most important point is this slide. Detailed costing analysis, we can do it for less than 30 lakhs. We can manufacture CAR T cells for a patient. Where is 30 lakhs and where is $500,000? Okay? This is without the cost of the vector. So we have a clinical trial going on right now. It's called the VELCARD study, named after Vellore. And again, I'm not going to go into the technical details, but for those who want the technical details, I'll be more than happy to give it to you. We manufacture it. It's live. Cells are infused live. And without going, we finished about 8 patients. Our phase 1 study is almost complete. Pictures speak more than any number of words. So this is a 59-year-old man from Kerala who came to us, who's with DLBCL, who had multiple lines of therapy, had an autologous transplant and relapsed, and he had DLBCL. What you're seeing on the left over here, not sure if my pointer moves, is a mass at the back of his neck, which is huge. And what you're seeing on this side is the bottom of his neck with huge lymph nodal mass, which you can actually put your hands and feel it. And this, he was thankfully in a good performance status, but had disease which was refractory to anything. He was on palliation with some lenalidomide and rituximab. And we took him up, and the pictures, adjacent pictures on the right of that and the bottom are just 28 days later after his own CAR T cell infusion. The disease disappears. It's really quite amazing. In my lifetime, I've not seen these kind of responses in refractory patients ever. So, we ourselves were excited, and some of the other patients did well. One patient died of progressive disease, but really, the power of the immune system is just awe-inspiring in many ways. I'll finally touch on something that I'm quite passionate about, and I'm sure there's many people in this audience. There's many things that you can do in your lifetime. You can do cutting-edge research, but people come in different modes and different shapes, and different things drive you. And I sincerely hope there's a group of people out there who will take the challenge of outreach medicine, which is equally challenging, equally impressive. So the missions outwork that CMC has, we have about 168 hospitals outside. We invest in training in our students, and we have a large number of students in the periphery who are involved in prioritizing and in transformational impact in many of these hospitals. I'll talk about what I mean by transformational impact. If you look on the right side of this map is the multidimensional poverty index map of the country. If you're looking at the middle areas and focus on the red, the yellow, orange, and red are high multidimensional poverty index. And on top of that list is Bihar. And in the north end of Bihar is a place called Madhepura, which I'll come to a little later. It's one of the most backward districts in the country. On the left is the extent of mission network outreach hospitals of CMC, where we directly or indirectly facilitate or do our best. We are not doing a great job in many areas. We are struggling in many of those areas. Some of those hospitals are collapsing. The bottom line for these places is you need people. You need people with passion, and that can make the difference. You can throw money at this, you can throw how much ever money at it, nothing is going to change. You find the right people, money doesn't matter. Everything will come in place. Now, does it stop at a hospital? And that's where the challenge in outreach becomes more. It does not stop at a hospital. Community relationships and outreach work becomes absolutely paramount and important aspect of your medical care. And when you talk about healthcare impact, there are two aspects one can talk about. One can talk about an incremental impact, and one can talk about a transformational impact. Incremental is when you have an additional service which is more easily accessible. It was always there, but now it's more easily accessible. Those are incremental. Transformational is when services become accessible to a population that has not been able to access these services. So Badepura I take as an example. In the north end of Bihar, one of the most backward places, Dr. Renu John is my classmate. She works in Australia. So what has she got to do with this? Every year for the last 15 years, when there was nothing there, the place was collapsing, we couldn't get doctors, she would go every year for 1-2 months in her leave, and she contributes money to try and build infrastructure that is there, spend some time in the community, etc. And then Dr. Arpit and Amy Matthew, his wife, landed up there in around 2017. I'm not going to talk about their hospital work. It is absolutely, and I encourage students here to go and visit these places. It's absolutely humbling what these people do with the limited resources they have. If you take a surgeon and from CMC and put him there, he'll say, no, all this can't be operated. You send him home to die. These guys do magic, absolute magic. Talking about a lady with an injury, with a laceration injury going across her face. Her brain is open, her eye is open, her scalp is open. And these guys are operating her in that environment, WhatsApp calling on video with the neurosurgeons in CMC, the maxillofacial surgery in CMC. 17 days later, she's well. If you talk about God and transformational work at work, you need to go see these places. Don't take my word for it. It is just astounding what they do. Anyway, Arpit and Amy came, and I'm not going to talk about their hospital work because that is truly impressive. But the amount of work in that community is incredible. It's transformational. They are working with rehabilitation, with educational services, with anti-trafficking, with income generation strategies, night schools for adults, night schools for children. There's so much happening over there. Now, this picture to you may not seem much. Sitting here in South India, we may, in parts of South India, not all of South India, may not make much of a difference. But the lady you're seeing in the front is a musahar. Actually, it's a derogatory term which you shouldn't use. They use another word today. This is a group, they are called rat eaters. Musahar literally means rat eaters. They are below the Dalits in the North Bihar, which is caste-driven in terms of status in society. And the lady right behind her is a Brahmin lady. And every group of castes is there in that one picture. And guess who's the leader of that group? The Musahar lady. Not an iota of bitterness, not an iota of anger. What they've done is these people have brought them together. They lease out land and grow vegetables and generate income. What happens in Bihar, for the most part, North Bihar, rich, fertile land owned by a few people, while 95% have no land and are poverty-driven, and they're all going out to work in other cities. Mass migration, the women sit at home and wait for their husbands to come back with some income at the end of this visit. Today, they're not waiting for their husbands to come back. Their husband comes back or not doesn't matter actually. Because now they have this farming going, they're leasing the land, they're generating the vegetables, they're growing, they're self-sufficient. Incredible. When you talk about transformational impact, I was so moved by this story because I went there, I traveled, I saw these people. It is just amazing what people can do. So a young person, a young couple, the transformational impact you can have is just unbelievable what is possible. I also bring about this component of service and suffering. They are not suffering there. Arpit and his wife, they're having a great time. I had the best breakfast I ever had in their house. They have music, they have socials, they have fellowship. They're having a great time. So we often think about going to these places as misery and think, yes, there are challenges, but don't confuse that with the joy of what you can achieve and do in your lifetime. I'll finally stop by saying, in summary, cost-effective care and excellence in Medicare. I tried to show you only through hematology examples, my apologies, it is possible. Education, service, and research are all integral. You have to have a high quality of education, you have to have integrity in your service, and you have to have a research bent of mind to say, how can I improve the outcomes of my patients? Your own data, own it, believe it. There is a world of need out there that needs transformational impact. One of you could be the spark. What is our calling? To share the pain of people, to respond and serve with love, to be the change we want to see. This is the prayer of St. Ignatius of Loyola. This is something that Dr. Arpit actually read out when he got an award this year. It says, "Dearest Lord, teach me to be generous. Teach me to serve you as you deserve. To give and not to count the cost, to fight and not to heed the wounds, to toil and not to seek for rest, to labor and not to ask for reward, save that of knowing that I am doing your will. Amen." I'll stop with that. And this is the picture of our new campus, the Ranipet campus, 1,500 bed hospital. Took us a lot of challenges to get here. And a big thank you, of course, to Dr. George Chandy, you may or may not know, was instrumental in stitching this entire land piece together. Not a mean achievement. Okay? And of course, there are many people who subsequently have gone on and contributed a lifetime to get it to where it is. Thank you for your attention, and take it from there. Thank you, sir.
Now, may I invite Father Sijo Pandupalli Lachan, Manager, and CEO and Director, Dr. George Chandy, to kindly felicitate Dr. Vikram Matthews with the citation for the excellent Decennalia Excellencia oration.
A refreshing tea break awaits you. Kindly make your way to the designated area where you'll find an assortment of beverages and light refreshments. We kindly request everyone to reconvene here in 5 minutes as we resume the program. Thank you.
Heavy on me, woke up and I'm feeling lonely. This world got a way of showing me. Some days it'll lift you up, some days it'll call you bluff. Man, most of my days I ain't got enough. And all I know is you're my only hope. When I'm up, when I'm down, when the wolves come around, when my feet hit the ground, I just need you on my darkest day. When I'm losing faith, no, it ain't gon' change. I just need you. Lord, I need you. Yeah, I just need you. Yea, though I walk through the valley of the shadow of death, I will fear no evil, for thou art with me. Thy rod and thy staff, they comfort me.
I didn't feel very much out of place. There was something to learn. And I'm happy to be part of the many who are here who are from CMC Vellore. And this brings back a lot of memories. And especially, I'm grateful to the management for especially calling me. Now, I'd happy to introduce Dr. Neeraj Siddhadran. He is the faculty of the Amrita Institute of Medical Sciences, and he'll be talking to us on thrombosis and hemostasis. From what I can understand, they're probably two sides of the same coin. Two sides of the same coin. And when we think of that, almost every clinician faces this. People who deal with patients face this in one form or the other, a dilemma. Dilemma on diagnosis, dilemma on what to investigate. Of course, we refer, and I'm sure they also have dilemmas because, as we heard from our professor during the oration, the research into hematology is going so fast, but translating it into treatment modalities has lagged behind. They say it takes about 10 to 17 years for something that has been discovered to come into clinical practice. And again, how to make it cheaper for patients, how to avoid side effects, and hematology especially, how to avoid giving another person's blood or blood products. All these are concerns that concern not only the clinician but also the clinician researcher. Thank you so much for being here. Thank you, and I'm sure Dr. Neeraj will have something which we can learn from. Thank you so much.
Thank you very much, sir, for that kind introduction. And good morning. At the outset, I want to thank Dr. Chepsi and the team at Believers Hospital, and greetings on the Founders' Day. It's really an honor and privilege to come to stage after Professor Vikram Matthews, sir, who has been my mentor too, and whose talk I'm sure must have inspired all of you out there. I've carried the same inspiration in the 13 years of my practice at Amrita after I left Vellore. So Chepsi has given this vast topic, thrombosis and hemostasis consults, and current challenges and best practices. So it's essentially, as Sir was mentioning, it's not going to be a hematologist here. These problems are mostly seen by all specialties, especially in the medical specialties as well as surgical specialties. You see thrombosis, you see bleeding, you see pre-op prolongation of PTA, PTT, and you have a patient with the DIC. You have patients with deep vein thrombosis, you have young patients with thrombosis, you have pregnancy loss, pregnant patients with thrombosis, so on and so forth. The consults from other departments are, huge in thrombosis and hemostasis. So as Sir rightly mentioned, it's two sides of the same coin. So you have it's a balance actually. So you have to find a balance. The body finds a balance in hemostasis. And if the balance is towards the clotting, that results in thrombosis. And if the balance is tilted towards bleeding, then you have hemorrhage happening. First, let us look at the clot. The clot is essential for us to survive because we need hemostatic clot. That is the normal clot. When you have an injury to the endothelium, the vessel there should be plugged. So the platelets and fibrins come and plug the site of injury, but essentially maintaining the blood flow. But what is a pathologic clot is where, classically seen in an atherosclerotic plaque,
you have the platelets and fibrin clotting and occluding the blood vessel. So you have the arterial as well as venous thrombosis, and principally, pathologically, there are two different clots. If you analyze it under a microscope, you will find more of platelets in arterial thrombosis, and you will find more of fibrin in venous thrombosis. That's the essential difference between an arterial and venous thrombosis. Arterial is more platelet driven, and venous is more, it's a mix more of fibrin driven thrombus. So Virchow had put this classic triad. We all know there are three elements to thrombosis. You have a hypercoagulability, you have the blood flow stasis, and you have the endothelial injury. Now, what are the examples of a blood flow stasis? Is when you are having a fractured limb, or you have a post-op period, you have a blood flow stasis, you have a polycythemia, you have a blood flow stasis. Endothelial injury, classically seen in trauma, surgery, central venous catheterization, etc. Hypercoagulability, everybody talks about inherited hypercoagulable state like protein CES, antithrombin, factor V Leiden, and prothrombin mutation. But there is also a lot of acquired hypercoagulable states out there, including antiphospholipid syndrome, myeloproliferative neoplasms, PNH, hormone replacement therapy, smoking, other inflammations, etc. The most common presentations that we see, of course, would in medical as well as surgical wards would be a deep vein thrombosis. Patient paraplegic in a medical ward would be predisposed to it, and a post-op patient in surgical ward would be predisposed to it. The symptoms, of course, we all know that calf swelling, leg warmth, and erythema would be there. And the most important complication that can arise from a deep vein thrombosis is a pulmonary embolus, where the part of the thrombus breaks off and travels to the pulmonary artery and clogs the system. The symptoms being dyspnea, chest pain, you can have sudden onset of loss of consciousness, a hypotension recorded, you may have findings in ECG, you can have tachycardia, and patient may or may not have the signs of deep vein thrombosis. So it's also important to define the clot. When you do a Doppler and find out a clot, sometimes it may be just reported a clot in the leg. So is it a superficial vein thrombosis or a deep vein thrombosis? That's the first question that we need to ask, because the treatment will differ. The treatment will differ because superficial vein thrombosis has less chance of going into the pulmonary artery, and a deep vein has a high chance. Is it a distal or a proximal DVT? That's also important, because a distal DVT has less chance of embolizing into the pulmonary artery. And then you should also look at it, the pulmonary embolism. Was it a trivial as low-risk pulmonary embolism, a submassive or a massive pulmonary embolism? So it is important to understand the anatomy. As physicians, sometimes we think anatomy is a surgeon's realm, but here we need to understand anatomy a bit. For example, in the upper limb, we have a lot of patients now on central venous catheters and developing upper limb thrombosis. So cephalic and basilic veins are superficial veins, and brachial vein is the deep vein. In the lower limb, the saphenous veins are superficial. The popliteal vein and upwards, the femoral vein is a deep vein. And the femoral vein is often called a superficial femoral vein, but even though it's termed as a superficial femoral vein, it's a deep vein. And anything below the popliteal, that is the gastrocnemius, soleus, and peroneal and tibial veins, are distal deep veins. So we need to understand these. As you can see in this figure, you can see the popliteal vein onwards is the proximal deep vein starts from here, and anything distal to that is a distal. And you have the saphenous veins, which are the superficial in the lower limb. And you have this brachial here, which is the deep vein of the upper. The brightly colored is a deep vein. And you have on either side, you have the basilic and the cephalic veins, which are the superficial veins. So essentially, the management of a superficial vein thrombosis can be a little less aggressive than a deep vein. So anatomy is very important for us to understand that. And almost always the consults we get, I ask questions about the genetic predisposition. But if you look at the deep vein thrombosis risk factors, genetic predisposition is only just one of the very minute or even sometimes negligible risk factor. Most of the other risk factors need to be considered, though. For example, cancer is a major risk factor. Patient with heart failure, a patient on stroke with paraplegia, patient who has post-op, smoking, long-term hormonal use in females, prolonged bed rest, pregnancy, have a fracture, prolonged travel, prolonged sitting, varicose veins, obesity, older age, prolonged standing, all these contribute as risk factors for VTE. So essentially, when you analyze a patient with a deep vein thrombosis, the question is the patient has a risk factor or not. If it is without a risk factor, you need to anticoagulate for a very long time, maybe 6 months to 12 months at least. But with the risk factor, you could cut down the anticoagulation to about 3 months. So it's important to understand and write down the risk factors for each of the patients. Like here, we can say that patient has a BMI high, for example, that could be a risk factor. A family history, a patient on oral contraceptives could be a risk factor. So on the other hand, you could have the same patient who has a bleeding risk. For example, the patient may be having a hemorrhagic stroke and the patient may be having a proximal deep vein thrombosis. So the imminent bleeding risk factors, the patient may be having a thrombocytopenia, patient in the ICU having a platelet of 20,000, may be having a deep vein thrombosis. Patient may be having a duodenal ulcer which is bleeding or an esophageal ulcer which is bleeding. So it is important to assess the bleeding risk also systematically at different time points. You could assess it at 4 time points. One is at diagnosis. At diagnosis, you need to say if there are any absolute contraindication to start anticoagulation. For example, if you have a hemorrhagic stroke, patient having a lot of edema in the brain, imminent conning, you may not start an anticoagulation because that may risk further bleed and risk to life. So that's absolute contraindications at the diagnosis. Second is upon discharge. You start a patient on anticoagulation and you are having so many other medicines. Warfarin have interactions, the Novaks have interactions. So at discharge, you should assess the bleeding risk, look at all the medications, interactions, creatinine clearance, etc. So you reassess the bleeding risk at discharge. And third time point is at 3 months. So at 3 months, you have completed your initial course of anticoagulation. At 3 months, if you have a provoked thrombosis with like somebody who's taking oral contraceptives, somebody who's had a pregnancy-related thrombosis. So a risk factor is no longer present. It was a transient risk factor and it was absent. You could stop the anticoagulation there or consider a reassessment there and whether a prolongation is required. And fourth is when a patient is on long-term anticoagulation at different time points, you need to see the patient and see whether the patient is continuing to have no bleeding or whether he has developed a new disease which he is bleeding, and then whether we need to come down on the anticoagulation. So it's a decision with different time points when a patient is being put on anticoagulation. And sometimes we have a practice of repeating the ultrasound. So Doppler ultrasound remains the most popular investigation to diagnose a DVT. Now, sometimes the patient may come with a previous history of DVT, and you do an ultrasound and you find a clot, and you don't know whether it's a new DVT or it's an old DVT. How do you differentiate? So sonologically, fortunately, there are ways and means by which you can differentiate. If you talk to a sonologist, there are 3 things that you can talk to the sonologist. So once the dimension of the vein, it is dilated or not, the echogenicity, is it hyper, or if the sponginess of the clot. So if the clot is very firm, hypercoagulable, hyperechogenic and retracted, it is likely to be a chronic thrombus. And whereas the other way, it will be an acute thrombus. But acute and chronic defined by radiology is not equivalent to acute and chronic defined in clinic. So we need to because an acute finding in a radiology may last for a few months. So the other thing, and I have put in this figure is, in the left DVT, if you have a patient with a left DVT, you should always consider an anomaly which is slightly above what the Doppler can see. The Doppler can see only up to below the inguinal ligament. So above that, you have the iliac vein. So you have an anomaly called May-Turner syndrome, where you have the left common iliac vein obstructed or compressed against the vertebral column by the anomalous the right common iliac artery. So that will be a continuous risk factor. So anybody with a left DVT, and especially if it is recurrent, this we need to keep in the back of our mind. And most often the consults are for doing thrombophilia tests. Sometimes when the consults are sent, already thrombophilia tests might have been done. So, there are certain caveats about thrombophilia tests that we should be aware. Do not test at the time of a thrombotic episode, because at the time of an acute thrombotic episode, invariably the levels will be low. If you check the protein C as an antithrombin, you will get a low levels. So there is absolutely no point in testing at the time of an thrombotic episode. And also when the patient is an inpatient, a lot of attention needs to be given to the patient's acute conditions, and we are not going to gain anything by doing a protein C as an antithrombin in an inpatient with thrombosis. So third is when the patient is on anticoagulation. Let's say the patient is on warfarin, you will find a low level. So there is no point in checking at that time also. And the most important thing is that, okay, if you don't know how to interpret the test and what to do with the result, we say don't test. So as you can see here, this table actually tells us that there are innumerable number of reasons other than a congenital deficiency where you can have reduction in protein C and S and antithrombin. For example, a patient with liver disease, disseminated intravascular coagulation, sepsis, nephrotic syndrome, patient on some drugs like estrogen therapy, and sometimes an acute phase reaction. So there are a lot of conditions in which these things can be altered. So we need to understand that before we order these tests. So nowadays, I think in hematology we would order very, very few tests of protein C as an antithrombin because of these problems. But more important is the acquired thrombophilia. You have the factor V laden and prothrombin mutation which are checked by DNA-based PCRs. So that can be checked, no problem. But most important thing is the acquired hemophilia, which sometimes get missed. So I'll talk a few slides on acquired thrombophilia. One is this, there are several recommendations. American Society of Hematology is there, International Society of Thrombosis and Hemostasis is there. But somehow I found personal preference that British Society of Hematology recommendations were quite good, simple, and very clinically based. So the two diseases, one is myeloproliferative neoplasms, another is PNH, paroxysmal nocturnal hemoglobinuria. So as these both diseases can present with clots at unusual regions especially. So the splanchnic, for example, splanchnic vein, the hepatic vein, portal vein thrombosis, almost even without a high platelet count, even without a high WBC, even without a high hemoglobin, it is advisable to check for a JAK2 mutation or a myeloproliferative neoplasm mutation panel in such patients. But there are also patients where you have a thrombosis at unusual sites and you have a high hemoglobin or a white cell elevation or a platelet elevation. In which case, yes, we should definitely check these. The other thing is about PNH. If you do a lactate dehydrogenase and if it is high, if bilirubin is indirect bilirubinemia, high retic, in such patients, there may be PNH. The other site, other than the splanchnic, where you find all this is in the cortical venous sinus thrombosis. So when you have these unusual sites, please bear in mind these things. So then you have the antiphospholipid antibodies where you can have APLA for unprovoked thrombosis or minimally provoked thrombosis. We should check for APLA. And we should also have check for APLA if you have presenting with multiple thrombotic episodes and organ failure. Now, about arterial thrombosis, generally it is not recommended to do thrombophilia testing, but you could do MPN panel or a PNH in such patients and an antiphospholipid antibodies. Neonatal, if you have a purpura fulminans, that is one indication to do protein C and S. Thrombophilia testing is not routinely indicated for neonatal strokes. And for antiphospholipid syndrome, those who are presenting with CAPS, we should do it. In pregnancy is another area where heritable thrombophilia testing is often done, but there is the recommendations guide recommend against, in bad pregnancy outcomes to routinely do for heritable thrombosis screening. But for that, you could do the antiphospholipid antibodies. That is an indication to do the antiphospholipid antibodies. And also, if you have an unprovoked thrombosis prior to the pregnancy, it is better to do an APLA if the patient is planning to conceive. Now, a word about newer anticoagulants. Now, we have, other than warfarin, you have factor Xa inhibitors, which is apixaban and rivaroxaban are available, and you have thrombin inhibitors, dabigatran. Factor 11 inhibitors are not yet marketed. What is important in this table, quickly I would say that rivaroxaban and apixaban can be substituted in many cases for induction. That is, instead of heparin or low molecular weight heparin, for a venous thrombosis, you could do an outpatient treatment with rivaroxaban or apixaban. And one indication where we are not preferring NOAC is antiphospholipid syndrome, where the efficacy of NOAC is considered to be inferior to that of vitamin K antagonists like warfarin. The laboratory monitoring is a challenge, but in an emergency, dabigatran can be monitored by an APTT, which would be prolonged, and rivaroxaban and apixaban by PT. But otherwise, it's the dilute thrombin time for dabigatran and anti-factor 10A for rivaroxaban and apixaban. If you have a patient with bleeding, bleeding is less likely in such patients, but if you have a patient with bleeding, then 4-factor PCC is one thing which is readily available, and dabigatran is dialysable. So idarucizumab is another agent which is available for reversal of dabigatran. Now, so much so about thrombosis. Now, moving on to hemostasis, we have hemostasis where different steps are there. Initially, when there is a subendothelial damage, you have the fibronectin deposition, then starts with platelet adhesion and aggregation, finally resulting in coagulation. So the platelets are exposed where the subendothelial collagen is it is bound to the subendothelial collagen by GP1A and 6, and also to the von Willebrand factor by 1B, and then you have the 2B receptor binding the fibrinogen. So 2B receptor binding the fibrinogen as well as the von Willebrand factor. And then you have the secretion of the granules which activates. So what's the importance is that, you have this 1B receptor, it binds for von Willebrand. You can have a von Willebrand deficiency resulting in bleeding, or you can have a 1B receptor deficiency called Bernard-Solier syndrome, and 2B receptor binding deficiency called Glanzmann's thrombosis. These are platelet function defects. And platelet function, how we can find out a platelet dysfunction, it's a very simple test called aggregometry, or it's an optical light transmission aggregometry. So this is the principle that you add an agonist for the platelet aggregation, and the platelet in a platelet rich plasma, and it starts aggregating. So the moment the shape changes, the graph curves, and you have the primary aggregation here, and then the secretion here, and then the secondary aggregation here, which will be finished in around 5 minutes. A typical case here, you can see that ADP, adrenaline, and collagen have similar aggregation of the red with the control, that is the blue, but in the ristocetin you find a low aggregation or absent aggregation. This can be the von Willebrand disease or Bernard-Solier syndrome. Here you can see no aggregation at all with ADP, adrenaline, and collagen, and there is an aggregation with the ristocetin, and here the diagnosis would be a Glanzmann's thrombocythemia. Now, these are the platelet function defect. The other arm of the hemostasis is, of course, the coagulation arm. So that you have the intrinsic factor. After the waterfall cascade theory, you have the intrinsic pathway where it starts from surface contact, and then 12, 11, 9, and then you have the 10, and the extrinsic pathway where the tissue damage, tissue factor binds to factor 7, and then final common pathway which results in the fibrin clot. So it is important to know this pathway because some of the age-old tests we still do, the PT and APTT are based on these pathways. For example, the PT is based on the extrinsic pathway and the common pathway, and APTT is based on intrinsic and the common pathway. So if you have an isolated PT prolongation, it means only the extrinsic pathway may be defective. If you have an isolated APTT prolongation, it means that only the intrinsic pathway may be defective. If you have both elevated, you may have a common pathway defect. But if you have a PT and APTT elevated, then many of the consults that we will get is because of the other departments, is because of the PT, APTT prolongation. I think the first step that we would want to know is whether it is an inhibitor or whether it is a factor deficiency. And how do we know? We actually do a very simple test called a mixing study. You have a normal donated plasma. You mix equal quantity of a patient plasma with a normal donated plasma. It can be done at room temperature or an incubated at 37 degrees, because some of the inhibitors are active at 37 degrees. So if it corrects, it shows a deficiency pattern, and if it doesn't correct, it shows an inhibitor pattern. So this is the pictorial representation. Here, if you have a patient with inhibitor, even if you add some normal plasma to it, the normal plasma, the factors will be there, which will again be bound by the inhibitor, and it will not be corrected. The APTT or PT will still be prolonged. But whereas it is a factor deficiency, you just add the normal factor and the prolongation will be corrected. So again, so the mixing study is the cornerstone in a coagulation test. And based on the mixing study, then you can decide whether it is an inhibitor. If it doesn't get corrected, inhibitor. What are the common inhibitors that we find? One is the lupus anticoagulant, and another, of course, is heparin is another inhibitor. D-dimer is another inhibitor that we find. And in patients with hemophilia, they may develop an acquired inhibitor, because they may develop an antibody. So in a patient, when you're analyzing a patient with hemophilia, this means they have developed an antibodies. So depending on that, we would go for the further tests. I'm not going into the details of that, but the point I wanted to emphasize is that the mixing study is which is the pivotal in going for an algorithmic diagnostic testing. So again, as I mentioned, you have the factor 7 deficiency in prolonged PT alone, and all the intrinsic factor deficiency in APTT alone prolonged, and you have the common pathways in PT and APTT together prolonged, and your anticoagulants can interfere in all of these. Warfarin, for example, can cause prolonged PT, and also it can cause prolonged PT and APTT, and some of the other anticoagulants can cause both PT and APTT prolongation. So I'll just skip this. But it is also, one more point I wanted to highlight is that when consults come, some of the factor assays have been done in an outsourced and outside lab. So we often get consults saying that, okay, factor 8 is 23%. And it is not matching with the patient's status. So what happens is some of the factors are very labile, because they get destroyed while sitting in the room temperature. So if you have a factor 8, which is 100%, and maybe after a few hours it will reduce to 50% or even less. So when the factors are being transported, ideally what should be done is they should be frozen, the plasma should be frozen at minus 20 degrees at least, and then transported to the lab. So there are a lot of pre-analytical, analytical and post-analytical variables in a test which may affect the coagulation testing. So this is very important to see that sometimes we may not need to take an action just based on an assay test result alone, because it may not be clinically correlating. The next thing is that these are all being tested in plasma, but in the human body there is no plasma separate. It is actually the whole blood circulating. So Maureen Hoffman and colleagues actually did some similar experiments which simulated the internal body environment, and then they found out the cell-based pathway of coagulation. They actually found that the coagulation happens on cell surface. There are mainly two cells on which it happens. One is the endothelial cell, another is the platelet. So as you can see, there is an initiation on the endothelial cell when there is an injury. A small amount of thrombin is produced. You need not understand the details of it, but initially a small amount of thrombin is produced. Then some things get activated on the surface of platelet. Platelet get activated, and on surface of platelet, a large amount of thrombin is produced, and that's how a clot is generated. To replicate, can we replicate that in the lab? Yes, we can, of course, replicate. Now there are technologies. This is called a thromboelastogram, where there is a pin and an oscillating cup, which actually tries to detect the clot formation in real time, and this is what it will look like. There is a lag time here, and this is the strength of the clot here. So if you have a clotting factor deficiency, this will get prolonged. If you have a fibrinogen deficiency, you will have this prolonged, and then a platelet problem, this will be a smaller amplitude of the platelet curve. And then you also have the fibrinolysis as the last part of the curve. So these are the different patterns in a thromboelastogram, or other thing is a rotum. So there are different applications. And liver transplant, those who are doing the liver transplant, I think they would be highly applying this because the blood products and all because you have a hemorrhagic tendency detected as well as a thrombotic tendency detected, and ultimately, as you can see, it is a balance between the hemorrhage and thrombosis that we see in clinical scenarios. So this is a good bedside test, especially in an operating table to use this. So, but most important test, if somebody asks, what is the most important test for hemostasis? What is the most important test? It would be the history. Okay. There's no other test which is as good as the history. So you have a patient who has undergone a surgery and who has bled, who has undergone a dental extraction and has blood requiring a blood transfusion. That patient surely would have a bleeding disorder. So there are subjectively you take the history, but nowadays there are objective ways to take history. That is called bleeding assessment tools. So these are widely available and you can easily use it from the internet. There are different tools, and tools are actually based on whether you are a male or a female, because for a female, a higher score is needed because they have menstrual periods. But for a male and a child, a lower score is considered significant. So the two main BATs that are being used now are, one is ISTH, International Society Thrombosis and Hemostasis BAT, and also the self-assessment BAT. And the patient can themselves do a self-assessment BAT. So now, I'm coming towards the end of the presentation, I thought I would just mention some of the very fascinating developments in hemostasis that has happened in the last decade. We all know the hemophilia, very difficult to treat disease. You need prophylaxis, you need a lot of IV injections, they develop joint deformities, a lot of bleeding every year, miserable life. But 3 drugs now are probably going to make their life much better, and they're going to live like normal people because of these 3 drugs probably. And one of them is already in the market, and some of you would know that this is emicizumab. Emicizumab is a bispecific antibody. Actually, it brings together, it has 2 arms, one directed against factor 10 and another against 9. So actually it brings together the both of these and substitutes for factor 8. And even if your factor 8 is not there, even if there is inhibitor, it doesn't matter. It substitutes for this and results in generation of activated factor 10A, which subsequently results in a clot formation. There's also, as Sir started with in the beginning, that it's a balance. Now people are trying to rebalance the hemostasis. So the rebalancing in other ways, pathologically occurs in liver disease. Liver disease, you have the anticoagulant proteins and coagulant proteins, and somehow it's a tightrope walking in a liver disease, whether it can thrombose or bleed. In normal hemostasis, you can see here in this picture that, sorry. So you have this, the clotting procoagulant and the anticoagulants here. And in hemophilia A and B, you have the procoagulants absent, and then the tilt is towards bleeding. Now, what people have done is they have now produced a monoclonal antibody against tissue factor pathway inhibitor and taken off the tissue and then rebalance the hemostasis. So that's the other molecule which has come up. This is called concizumab. And there is also another molecule called fitusiran, which is a small interfering RNA directed against antithrombin. And so the antithrombin usually inhibits the thrombin. So when the antithrombin is inhibited by the fitusiran, thrombin generation occurs and the clot formation occurs. So these 3 drugs are now considered for hemophilia with and without inhibitors. The last 2 for both hemophilia A and B. And if you look at the, just the results, you can see here that emicizumab, the patient, the comparison group is here, those who have the bleeding, and you see there are many patients who actually live with 0 bleed. It's a truly revolutionary development in hematology. And this is the latest NEJM, just published, the phase 3 trial of concizumab for hemophilia with inhibitors, both A and B. So you can see that with the concizumab, which is the tissue factor pathway inhibitor, your bleed rate really comes down as compared to the no prophylaxis group. And the same for the fitusiran. You can see that a large majority of the patients develop 0 bleeds. About 50% of them have 0 bleeds, which is kind of unimaginable in the conventional replacement therapy in the past. So I think to conclude, I would say that in-depth understanding of physiology of thrombosis and hemostasis has indeed led to rapid developments in diagnostics and therapeutics. In fact, the translation is happening very fast. the approach to a patient with thrombosis has to be personalized and appropriately investigated for acquired thrombophilia particularly. The newer anticoagulants are now here and they have proven safety and efficacy. And objective history and careful interpretation of the laboratory results are cornerstones when investigating a patient with bleeding. And novel drugs with a unique mechanism of action are now revolutionizing hemophilia care in the field of hemostasis. With that, thank you very much for your attention, and once again, thank you, Chepsi and team.
Thank you, Neeraj, for the wonderful presentation. And he has very well described the important topics, thrombosis and bleeding, which is having a high morbidity and mortality. And also he very well emphasized the importance of the history taking and clinical examination rather than purely depends on the lab findings. The topic is open for discussion.
Just 2-3 questions. Now you said superficial vein thrombosis is not that important. Can you 100%, no, superficial vein thrombosis, should you anticoagulate? You need not, or we have to weigh the balance?
Sir, there are some, if I've said that, I should correct myself. So what I meant was that superficial thrombosis is treated a little different from deep vein thrombosis. It is not that it shouldn't be anticoagulated. There are, like, if there is a risk, essentially it's all based on the risk of a pulmonary embolism from the superficial vein. So if you have a large clot and it is near the connection, so there are a few guidelines on which we would say that, okay, if they satisfy these, yes, it's better to anticoagulate, but for probably 6 weeks would be enough than the 3 months.
Thank you. You said there is no need for testing for hypercoagulability in arterial thrombosis. Did you mention that? Arterial thrombosis.
Hypercoagulability, yeah, antiphospholipid, yes, we should. We should. But protein C, protein S, antithrombin, the guidelines mention that there is, the guideline mentions against it.
Any reason for that?
The chances of finding, because the arterial clots are, sir, more platelet driven and plaque driven, so it is very less likely that protein C, S and antithrombin would contribute, congenital deficiency would contribute to an arterial thrombus. So they had studied, and different studies have looked at it, and the percentages were very low. So that's why the recommendation is against.
Okay. One more thing, PNH, I think it comes with arterial thrombus as well as venous thrombus. Am
Yes,
I right?
Yes, sir.
Have you seen patients with PNH?
Yeah, definitely, sir. So PNH comes with both arterial and venous thrombosis.
Another thing is JAK2 mutation. You said it can present even without thrombocytosis as well as polycythemia with thrombosis.
Yes, sir.
I had one patient. You know the patient, Raju, I sent to you with a very high platelet, 20 lakhs patient, and he initially had a splenic vein thrombosis. We had done a splenectomy. After few years, he developed a pulmonary embolism. Then later, he came with a platelet count of 10 lakhs, 15 lakhs, 20 lakhs. So what is the mechanism of that JAK2 mutation? Producing thrombosis without thrombocytosis or polycythemia.
So the JAK2 clone is a thrombophilic clone. I mean, even when actually for example, sir, if the platelet count is 4 lakhs, it's a clonal disease. All 4 lakhs patient platelets are abnormal platelets. So it's not that you have you have to have a thrombocytosis. It's not like a directly proportional thing. You could have, there are patients who develop ischemia at 4 lakhs or 5 lakhs platelet count itself. So it's not directly correlating with the platelet count as such. Rather, it is the clonal disease. So because of the clone has the tendency to form the clot.
Thank you.
Yes, sir.
Thank you, sir. It was a very detailed discussion. I'm from the lab's perspective. I have some questions. I have 2 questions. One is, we know that the inherited thrombophilia is rare, and but we are testing, every laboratory they are testing it. So I want to ask you, at what point during that, you said acute event, we don't do it. Even we don't recommend that. And when patient is off anticoagulants is what we require. We put a footer under that. So when do you find that time? How practical is it during the...
Yeah, so thank you. That's a very good question. So, uh, yeah, so what happens is the patient presents with an acute thrombosis. So there is no need for any testing. Concentrate on giving the appropriate anticoagulation immediately. Okay, you could treat the patient as inpatient or outpatient. You can even ambulant. If there is a requirement for inpatient admission, yes, you can admit. But just because of the thrombosis there, you don't have to admit. But you treat the patient. And the initial thing is, okay, you treat either with a low molecular weight heparin or Novak. So you give an induction dose. Induction dose may last from 5 days to 7 days to 2 weeks or up to 3 weeks. Let's say for rivaroxaban, it's like 3 weeks. Do you do a testing during this period? No. There's no need to test this period because stopping the anticoagulation will be more risky during this period than actually finding out a cause which doesn't have a particular treatment. If you find out protein C or S deficiency, then very unlikely. Now, then you continue the anticoagulation. After the intensive phase, you continue the anticoagulation for 3 months. Now, the 3 months is the next time point that we take a decision. At 3 months, you see the clot, whether it is resolved and all those things is done, and you analyze your risk factors. Now, you analyze your risk factors and find that, okay, not many risk factors are there. You want to continue. You could still continue the anticoagulation even without testing, because if an unprovoked thrombus has occurred, what is the use of testing? You have to continue the anticoagulation. Even if the testing becomes negative, you should still continue the anticoagulation. So I would, but if it's kind of, you're not sure, the patient had a 6-hour journey, not sure whether that has provoked, you want to do some testing. There's some family history where somebody has developed a stroke, some maybe cortical venous thrombosis at young age in the family, and you are in doubt. Okay, you are in doubt, and you think there was a transient risk factor. 3 months is the time where you could actually hold the anticoagulation and do a testing. If it's a warfarin, you can hold it for a week. If it's a Novak, 1 or 2 days holding would be good enough. 2 days of withholding Novak would be good enough. At that time point, you can do a testing for protein C, protein S. Another indication for a protein C directly would be a purpura fulminans in a neonate. That you can do because if your anticoagulation, first is you have to optimize the anticoagulation. Before starting anticoagulation, you can do that in a neonate. Because there, if your anticoagulation is resistant and if you have access to protein C concentrate, you can treat that patient with a protein C concentrate. So that is the other only indication which I can think of where you can do it at the onset.
So do you recommend a complete thrombotic panel? Because what we've noticed is that selective things are being ordered, like a protein C, S, antithrombin 3. If at all, then they will order MTHFR, that mutation, or a prothrombin gene. So what would you recommend, the complete panel or a screening panel? I mean, is there a relevance for that?
So MTHFR and the other, so apart from protein C, S, antithrombin, factor V Leiden, prothrombin gene mutation. These are the 5 genetic predisposition conditions which there is an association which is indisputably found. The MTHFR and the other rarely done panels, I think it will most often confuse the picture. MTHFR may sometimes be helpful in some patients with arterial thrombosis because some of this, because it's more of an endothelial released product, and so it may be sometimes be helpful. It's not in the recommendation though. It's not in the recommendation. So I wouldn't recommend any panel as such. It would be from the clinic. You have to see the patient and assess. If you have an antiphospholipid, you add, and it will be more acquired thrombophilia that I'll be concentrating. And even in young patients, young females who come, you find a lot of acquired thrombophilia, including antiphospholipid syndrome, as against very low incidence of the other thing. And even when you get the protein C, yes, we are still not sure whether it is actually a deficiency. Is it otherwise?
polycythemia, it can prolong prothrombin time, no?
Yes, sir.
Sometimes,
Yes, sir.
So I want to mechanism.
Yeah. So basically, basically you have the citrate added to the, when you take a citrate tube, you do the PT and APTT in a citrate tube. So sir was asking about in a polycythemia, when you have a high hematocrit, you may find if you do a PT, invariably the PT will be prolonged. So there is a mechanism for that, because citrate tube which is available in coagulation labs have a fixed amount of citrate added to it to nullify the calcium in the fixed amount of plasma which normal people have. But in a patient with polycythemia, let's say the hemoglobin is 20, the hematocrit is so high, the total volume that you're adding is the same. So the plasma remarkably comes down. And so the more calcium is chelated, and then you have your PT artifactually prolonged. Now, what is the solution? Talk to the lab before sending it. The lab will actually send you a citrate tube where the citrate is put according to the hematocrit. There's a formula according to which they will put the citrate and then send you.
I know though, a lot of questions are waiting for you. Because of the lack of time, we will wind up this section. Thank you once again.
Thank you, sir. Thank
Dr.
you, sir.
Neeraj.
Thank you, sir.
Thank you, sir. It is my pleasure to invite Dr. Elizabeth Varkey-Cherian, Senior Consultant Pediatrics, Quality Coordinator NABH, Believers Medical Journal Editor, to felicitate the speaker and the moderators. Thank you, ma'am. I'm thrilled to welcome our next speaker from our very own family, Dr. Bonnie Anna George, Assistant Professor, Pathology. She has been an exceptional educator, sharing her vast knowledge and expertise with medical students, residents, and fellow pathologists. Her contributions to rectum cannot be understated. Her conclusions are sharp and brisk, and they have come to aid every single time in the early management of cases in crucial stages. It is my pleasure to welcome Dr. Bonnie Anna George to share her insights on interpreting peripheral blood smear, a guide for non-hematologists. I would like to invite the moderators for this session, Dr. Rima Miriam Abraham, Assistant Professor, Hematopathology, Amrita Institute of Medical Sciences, and Dr. Elizabeth Joseph, Professor, Department of Pathology, and Vice Principal, Believers Church Medical College Hospital.
Good afternoon. Actually, I'm really honored to welcome you all to this session on interpretation of peripheral blood smears, a guide for non-hematologists. As you all know, the most common laboratory investigation that's being carried out routinely is the peripheral smear. And a drop of blood onto a glass slide can give us a lot of information that is useful for the diagnosis as well as for the management of patients. And most of the time, this peripheral smear interpretation is straightforward, but in rare occasions, it can be very much challenging. So in those occasions, I think it is very much needed that the close interaction between the clinician and pathologist is essential for to arrive at a final diagnosis. So to enlighten us on this topic, we have our own Dr. Bonnie Anna George. She has done her postdoctoral fellowship in laboratory hematology from CMC Vellore, and after that she joined our department. Now she's taking care of all the hematopathology cases, and she's in charge of the hematopathology division. And today she will be discussing about the complexities that are surrounding the interpretation of peripheral smear. Over to you, Dr. Bonnie.
Thank you, ma'am. Warm good afternoon to everyone. So, peripheral smear examination, that's the topic. It appears quite basic, but over the next 25 minutes, we would see that even now, a peripheral smear examination, it still holds a lot of information and gives us a guidance to a clinical diagnosis. So, hematology rests on three pillars: man, morphology, and machine, of which morphology is at the core, and it is the central pillar that gives us a direction to what is happening with the patient. So why a peripheral smear? It gives us clues, points directly to a diagnosis. It helps us to assess how the marrow is functioning, and in certain diseases it helps us to monitor if the disease is progressing. And also, most of the blood samples routinely is run through our automated analyzers, and results are given. Those results need to be checked before they are released. So many of them can be counter-checked only by a peripheral smear examination. Now, based on what we have seen over the last 1 year, how are peripheral smear requests being made? One is the clinician-driven request. That would be probably the first time the patient has visited their OP, or there are some unexplained cytopenia or cytosis. Now, as part of tropical fever workup, to look for hemoparasites, to monitor any adverse effect of drug, which can cause a drug-induced neutropenia, and also to monitor response to treatment or any interventions that was done in the form of hematinics or transfusion or chemotherapeutic drugs. Now, from the lab side, when do we review? We review it when there are abnormal cell counter results or flags generated on the analyzer. Now, every accredited lab will have a slide review criteria. We have our own, and this is irrespective of whether a peripheral smear is ordered or not. Based on that, we review the results of patients that are generated on the analyzer. Now, through some cases, let us see how a peripheral smear and morphology examination helped us arrive at a diagnosis. Case 1, this is a 73-year-old lady referred to believers in view of severe anemia, decreased appetite, general weakness with mouth ulceration. And the CBC profile showed a very severe anemia, hemoglobin at 4, with macrocytic indices. Total count was holding steady with a mild thrombocytopenia. So this is definitely a criteria to review the slide. And as you can see, the RBCs are quite spaced out. So this is keeping in line with the degree of severe anemia, and most of them are large. We call them macrocytes. And if you look here, you can see the large and oval-shaped cells that we call macroovalocytes. There were nucleated RBCs, which are usually not seen normally in a normal person. Only if the marrow is stressed or in states of increased erythropoiesis does it come out. Mild degree of poikilocytosis is there in the form of teardrop cells and few fragmented cells. Then another thing that we note in the peripheral smear, in the body of the report, if you look at it, would be the presence of these Howell-Jolly body or basophilic stippling. These stipple cells will have blue dots singly scattered. So what do we mean by that? This tells you that the patient or this person is in a state of accelerated or disturbed erythropoiesis. So these findings in isolation is not conclusive of anything, but when the findings are taken together, it points to a direction. Now, when you look at the WBCs, we see hypersegmented neutrophil in this patient, which is more than 6 lobes. And putting all the features together, these features are suggestive of megaloblastic anemia. So vitamin B12 levels were done. This was found to be low. And on further probing, it was found that she was a strict vegan, and she was transfused and given on vitamin B12 supplementation. Now, coming to case 2, this is again a 79-year-old lady She had very vague symptoms, insomnia, dizziness, pallor was there on examination. Past history, she had a CAD-ACS syndrome. She is on anticoagulants, and when we ran the sample in our analyzer, this is what the instrument generated. That is very low values, very low, like just 4 or 40 WBC, very low, and none of the RBC indices could be calculated. Now, from the lab perspective, when we see this, that comes under our criteria for review. So when we reviewed the slide, this is what we saw, and this is RBC. All the RBCs have agglutinated. Now, how did this interfere with our analysis? So it goes back to the Coulter principle. Many of us have heard about it. Just to say that the analyzer has in its algorithm, in its working principle, you have the cells are counted as it passes through a aperture. When it passes through the aperture, it breaks the electronic circuit, generates resistance, generates a pulse. Now, all these pulses are in many events. They are calculated together, and all those events that fall within a certain size, like 25 to 250, those are calculated in the RBC zone. Now, when you have agglutination, you have masses of red cells which go through this aperture, and this goes beyond the linearity or the instrument measuring capacity. So what did we do? We incubated the sample at 37 degrees for 15 to 20 minutes, and we made a repeat smear. So as you can see, the RBCs have separated out. The agglutination is minimal. And the same sample, what we saw was there were those large cells, macrocytes, but on closer examination, they were polychromatophils, which represents reticulocytes. And few NRBCs were also there. Same sample after warming, when we ran in the machine, it gave the indices, an anemia of 8 with macrocytic indices, and fairly normal. So we reached a conclusion that this is autoimmune hemolytic anemia, cold antibody type, maybe a component of mixed is there. Patient was worked up further. DCT has come positive. She had an autoimmune panel workup done. It came positive, and she was treated, and she's doing well. Now, coming to case 3, 27-year-old lady, fever and dry cough for 2 days. She was referred to Believers because outside, when she did her CBC at a local lab, she was detected to be a severe thrombocytopenia. So in this time of acute febrile illness, maybe they thought dengue and they referred. So when we ran in our analyzer, yes, it is correct. All indices were fairly normal except the platelet count, which was severe, less than 10,000. But when we reviewed the smear, this is what we saw. Platelets are present, they have agglutinated, they have clumped. So this is probably this is where a slide review really takes importance here, because this can only be found out on a slide review. Even in the body of the film, you can see platelets are seen in clumps. Now, if to give a range, it's not possible when platelets are seen in clumps. What we need to see is platelets singly scattered. We count them under oil immersion. We have a multiplication factor, and we give a range, which you may be seeing in our reports. But when platelets are in clumps, that's not possible. But we can safely say that platelets are adequate. There is no risk of bleeding in this patient. Now, why does this happen? That is because the instrument has set a threshold to count platelets whose size falls between 2 to 30 femtoliters. So if you have platelet aggregates and clumps, this bypasses this threshold, the upper discriminator. So it doesn't get counted as platelets by the machine. Now, case 4, 51-year-old lady, fever for 2 days, multiple episodes of vomiting, altered sensorium, quite restless. Past history, she gives a history of rheumatoid arthritis on Ayurvedic treatment. So when we got the CBC was ran, it was showing anemia with mild thrombocytopenia. There was a leukocytosis, which was neutrophilic. So again, we reviewed the smear, and as you can see, the RBCs there's increased spacing between them, so there is anemia. And if you can see that some of the RBCs here are fragmented. This is what we call schistocytes. So what qualifies as a schistocyte is, again, fragments of RBCs. They appear with sharp ends and borders. So that is seen in every field. Along with that, you can see these cells with these thorny projections. And this is what we call Burr cells or echinocytes. So usually, Burr cells come as part of an artifact, that's a common one, but it also indicates that there is uremia or some renal failure happening in the patient. Further, other field seed showed that there were nucleated RBCs, more schistocytes as can be seen, and you can see microspherocytes. So what happens is when the RBCs fragment, whatever remains behind, they coalesce together and form the most stable shape in the universe, which is a sphere. So depending on how much got fragmented out, it depends on what remains behind, that depends, governs the size of the spherocyte that forms. Now, when we did a manual platelet count on the smear, it was lower than what the machine detected. We got like between 90 to 1,05,000. Again, not dangerously low, but it was lower than the machine. Now, how is this explained? You can see in this picture that these are microspherocytes. This is a platelet over here. This is also a platelet over here. Now, the sizing is somewhat similar. So what happens? The machine, so all the RBCs that were supposed to, that falls between 30 femtoliter to almost 250, they get counted in the RBC zone. But if you have RBCs which are very small, similar to a platelet size, it falls in the platelet sensing zone. So that was a case of a falsely elevated count. So based on the features, it was given as microangiopathic hemolytic anemia with mild thrombocytopenia. This patient was further worked up. At that time, they thought of TTP based on the clinical presentation also. ADAMTS 13 levels were sent. Meanwhile, her clinical condition kept deteriorating. Blood cultures came positive. And there was the interim diagnosis was septicemia with septic encephalopathy. But she had a very fatal course and the patient expired. Now, schistocytes, it's a danger sign. When you see schistocyte, more than 1%, it is significant. However, schistocytes can form two ways. One is if there is a mechanical damage to RBCs, that is when the RBCs go through a thrombi, the fibrin strands will slice and dice the RBC and release the broken fragments out. Now, that is a mechanical damage. The second way of its formation would be shearing forces. That is, if you have a large cell going through a narrow vessel, just by means that it's a tight fit, just because of that and the laminar and the flow of blood, those RBCs will shear off and you get fragments out. Now, so schistocytes is not exclusively, does not exclusively tell you that it is a thrombotic microangiopathy. One should be aware of the non-thrombotic microangiopathies too. So, again, if there is a thrombotic microangiopathy, invariably there will be thrombocytopenia because it is consumed in the formation of thrombus. If it is a non-thrombotic microangiopathy, may not, or the degree of thrombocytopenia would be less. So we have to be aware. So in neonates, physiologically, it is macrocytic, that is normal at that age, and we do see fragmented RBCs. It is not, and the threshold for them is even higher as normal, okay? But in our dialysis patients, those with malignant hypertension, also schistocytes come up. Okay, now the next case is 59-year-old lady, low backache, generalized body pain, fatigue. She was being taken analgesics, no improvement. She came here and what we got there, she has an anemia of 8.1. Her up counts are on the upper limit and there was mild neutrophilia with a left shift and there is thrombocytopenia. So this is a low power view and we could see that there are some big round cells. So our first doubt while screening is that what are those big cells? Could they be blasts? So looking under oil, we saw that these were the immature myeloid precursors. Like there was a left shift. It was mostly metamyelocytes and band forms. And also there was nucleated RBCs. So when the nucleated RBCs was very high, 16 in 100 WBCs counted. So when such a high number comes, we will correct the total count. Why? Because nucleated RBCs will interfere with WBC count by the machine. The machine will count the nucleated RBC as a WBC. So you will get a falsely elevated value. So that's why we correct the TC. And in this field, in some of the areas, we could see teardrop cells. Now, teardrop cells is non-specific, but in the context of a left shift, it holds significance. So this is a leukoerythroblastic blood picture where all the immature precursors have come out with teardrop cells. So that was an indication for marrow, and trophine biopsy was showing that this is the bone trabeculae. We see the tissue in between, and the normal architecture of the bone marrow is completely lost. It is replaced by cells foreign to the marrow. These cells are neoplastic, all features of aneuploidia present, and this is suggestive of bone marrow metastasis. And some of those cells show what we call signet ring morphology, where the nucleus is pushed to the periphery, and based on this, the primary could be a breast or GI. So this leukoerythroblastic blood picture, it occurs when the marrow is stressed in acute hemolysis, hemorrhage, fulminant infections. But bone marrow infiltration can also cause a leukoerythroblastic blood picture. So hence, if there is a leukoerythroblastic blood picture in your peripheral smear report, it warrants a bone marrow examination. So next case, a 76-year-old male, again fever, with cough, and he was referred from elsewhere. He had elevated total counts, raised CRP, deranged LFT, RFT. He had a fever workup done, that was negative. Blood culture was done, no growth, and he was on IV antibiotics when he came here. So we got a leukocytosis, and there was just a mild anemia with normal platelet count. On examination of the smear, what we saw was that there are these large cells. So right in the center, we have something that can be taken as a normal lymphocyte, small. But these cells, these are large. These are large, and they have very convoluted and folded nuclei. There's got more cytoplasm, it's bluish. Further fields showed almost a flower-like. This is what we call flowers, but not as sweet. These are deadly flowers. So this is based on the morphology alone, this was favoring adult T-cell leukemia, lymphoma. So the case was referred to hematology, and they worked it up, and a bone marrow was done, but there were only scattered cell in that sample, and the sample was dilute, so they got only a clonal population of 5%, but it was followed up with an HTLV virus report, which was reactive. Now, in the last 2-3 months, we've been dealing with a lot of acute febrile illnesses and in different forms. And what we see a lot of reactive lymphocytes. And these lymphocytes, they are different from what we see normally, in the sense they are bigger, and they're more bluer, and the nucleus also has these prominent nucleoli. So based on this and the features that with the clinical history of fever, sore throat with cervical lymphadenopathy, and the fact that some of these reactive lymphocytes, if you can notice, the cytoplasm is scalloping and just hugging the RBCs. This is what we call skirting, like a ballerina skirt. And these favor downy cell morphology, which we have heard in the context of infectious mononucleosis. But then comes the other player that we have been seeing, that is dengue. In dengue also, we are getting these lymphocytes, which are more bluer, which are more, bolder, and some of them have really irregular outlines. So as you can see, the line between distinguishing differentiating a neoplastic from a reactive can be thin. You cannot rely only on morphology sometimes. So that's when the machine comes into play. So in the new generation analyzers, we have the basic Beckman-Coulter analyzer running on Coulter principle, and then you have the fluorescence technology-based analyzer. We have one in our lab. And what does it do? Based on, it has a dye, which is a fluorescent dye that incorporates into the cytoplasm of the cells. And based on the fluorescence signal intensity and the light scatter properties, your WBCs are differentiated. So you have lymphocytes over here, close to the monocytes. neutrophils, eosinophils. So this is a normal patient. But when you see cases with these reactive, highly blue and cells, we've noticed that there is a separate population forming right above here with more higher fluorescence. And this is what we noted in dengue patients. So this is denoted as the analyzer as high fluorescence lymphocytes. So we use this to aid us in deciding whether it is reactive or not. Now coming to the last case, a 1 year, 1 month female child referred in view of microcytic hyperchrome anemia with inadequate response to iron therapy. Nothing significant, otherwise just anemia. There's history of anemia in the maternal aunt, and the grandmother is from Aurangabad. Anyway, the CBC was run here, and hemoglobin is low with very severe microcytosis, 52.7, and it's hypochromic indices. But if you can note here, the RBC count is fairly normal. So we examine the peripheral blood, and the peripheral blood is microcytic, keeping in true with the CBC picture. And we see along with, so when what we call microcytes is based on roughly the size of the nucleus of a lymphocyte. So everything is small here. And apart from that, you can see these target cells. And in this field, we can see irregularly contracted cells, like misshapen ones, small misshapen ones. And this is what we call a blister cell, where part of the hemoglobin is lost. So putting all this together with the microcytic it's not findings that some of these findings will be there in iron deficiency anemia, but more target cells, more of these irregularly contracted cells, that would favor a hemoglobinopathy rather. Iron profile was done, that was normal, and we have an HPLC hemoglobin variant analysis was done here, which showed the characteristic HBH peak. This is followed up with the mutation analysis, which showed a homozygous deletion. So the patient was counseled, family screening is advised. So we have seen that how morphology helped point out the direction or open the window to the clinical diagnosis, but with the support of man, that is clinician and pathologist, and the machine. So with this, I come to the end of my presentation. Morphology never lies. Thank you.
Thank you, Dr. Varni. Your case-based illustrations were very useful for both hematologists and non-hematologists, and for stressing on all the interferences that can affect a report, and for reiterating how important the dialogue is between the clinician and the pathologist to arrive at a good diagnosis. So now the floor is open for discussion, if any comments or queries from the audience.
Very nice talk.
Thank you, sir.
Much benefited. You are talking about pseudothrombocytopenia, no? What is the mechanism of platelet cytolytism? The platelets clumping around the WBC.
So autoantibody activation. Some people are more sensitive than others.
No, why around the WBCs? That is called platelet cytolytism.
Yes, sir. It's agglutination. It's part of that.
It so
only.
happen
Yeah.
around. That's all.
Yeah, but it's also, I haven't, it's quite rare, more compared to EDT-induced pseudothrombocytopenia. This is even more rare. I don't know. Dr. Reema, do you have any? Same, yeah.
I know EDT induced, but NEJN gives this one platelet cytolytism, some antibody they are mentioning,
Yeah,
which is attached to the WBC also. I am not sure about it.
Yeah.
Okay. Number 2 is microangiopathy hemolytic anemia, that schistocytes are not specific. That's correctly said. It is that you also said about the mechanical hemolysis due to mechanical valves,
Yes.
Warren Blender syndrome.
Yes.
That's also good.
Yes, sir.
Thank you so much.
Thank you.
If no more questions, we'll wind up the session. Thank you all.
Thank you, ma'am. I'd like to invite Dr. Sujit Philip, Senior Consultant, Gastrointestinal and Hepatobiliary Surgery, to felicitate the speaker and the moderators. Thank you, sir. Transfusion medicine plays a vital role in patient care and safety, and it is an area that is constantly evolving. It is a field that requires constant research, collaboration, and innovation to improve outcomes and ensure the safety of transfusion practices. For the final session of the day, I would like to introduce Dr. Lakshmi Sudev, Assistant Professor, Immunohematology and Blood Transfusion, Regional Cancer Center, Thiruvananthapuram, to edify our knowledge regarding transfusion medicine consults beyond blood products. I would like to invite the moderators for the session, Dr. Anupa Jacob, in charge, Transfusion Medicine, Believers Church Medical College Hospital, and Dr. Abraham Samuel, Head, Medical Oncology, Believers Church Medical College Hospital.
A very warm good afternoon, one and all. Believers Church Medical College Hospital is indeed close to my heart as I began my career here back in 2018. And I feel very much honored and privileged to have been invited here for a talk, and that too for the 10th Founders Day. And I will also like to thank Dr. Chepsi, Professor and Program Director, for the opportunity. So let me begin the presentation. This is an outline of my presentation. So I have included a few case scenarios in which a transfusion medicine consultant has to go beyond blood products for clinical improvement. And I have included a few cases, and we will have a case-based discussion based on the rationale and indications of the same, some evidence-based guidelines, an example for a goal-directed therapy, and also for an incompatible RBC transfusion. So nowadays, stored whole blood transfusion has become obsolete as all the coagulation factors, mainly the labile factors 5 and 8, the level gets decreases, the platelets lose their viability, and basically whole blood just becomes red cell suspended in a protein solution. And studies have shown that fresh whole blood has a role, and that too only when platelets are not available and in hemorrhagic cases. And modern transfusion therapy focuses on component therapy rather than whole blood therapy. And as you all know, these are the 4 blood components that are derived from whole blood used in clinical transfusion practice. So coming to beyond blood products, coming to the first case, it's a 12-year-old boy who's a known case of sickle cell anemia who presented with seizure, dysarthria, and weakness on one side. An urgent CT scan was done which revealed acute stroke. And to improve oxygenation, the question was whether to go for a simple transfusion or a red cell exchange. And here it's a vaso-occlusive event with sickle cells blocking the vasculature, and acute stroke occurs in 10 to 30% of the cases, and our main goal was to go for a red cell exchange. And according to ASFA guidelines, acute stroke is a category 1 indication for RBC exchange, and even for prophylaxis in non-acute stroke, it's a category 1 indication. So what's the rationale for red cell exchange? The rationale is that the sickle cell red cells are replaced with normal donor red cells, and there is rapid adjustment of hematocrit and HbS levels, and since the deceased sickle cells are replaced with the donor cells, side effects like iron overload or volume overload, everything is quite less. And with the help of a modern apheresis equipment, an ml to ml basis replacement is possible. And so what's the goal of the red cell exchange? Our main goal is to bring down the HbS to less than 30%, the hematocrit to less than 30%, and HbA 70%. And so this can be achieved with the help of apheresis equipments. Many equipments are available in the market currently. And so our goal is to bring the HbS to less than 30%, and for that the fraction of cells remaining, it depends on the hematocrit as well as the total blood volume of the patient, and it can be calculated using this formula. And this is a display panel of one of the machines used for therapeutic procedures. And here we can, different programs can be chosen. And the weight of the patient, the hematocrit, the HbS level, everything can be added. And we also have an option to provide the volume and hematocrit of the red cell units that we are using for exchange, so that basically ml to ml basis exchange is possible. And the replacement fluid that we are using is donor red cells. It should be less than 7 days old. It should be ABO compatible, and that too in the AHG phase. It should be RH, KEL and KIT matched. It should be leukodepleted and HbS negative. And the frequency till which the procedure is to be done is till the target HbS level is achieved. And the therapeutic apheresis by red cell exchange is very useful in sickle cell anemia, but it's often underutilized. And the other indications are for red cell exchange are hemochromatosis, malaria, erythrocytosis, polycythemia vera, etc. So coming to the next case, it's a 54-year-old male who's a known case of polycythemia. He was on routine therapeutic phlebotomy and he had a past history of TIA, and he was referred to hematology department as his platelet count was 16 lakhs. And he was treated with injection cytosine, but still the platelet count further increased, and hence transfusion medicine consultation was sought. So this is the parameters. Even after injection cytosine, the platelet count increased to 19 lakhs, and the treatment modality we could offer was thrombocytopharesis. That is for thrombocytosis with a circulating platelet count of more than 4.5 lakhs. Again, according to ASFA guidelines, it's a category 2 indication when it's done symptomatically, and a category 3 indication when it is done as prophylaxis. These are the different causes of thrombocytosis. There are clonal causes, reactive causes, and spurious causes. And for the clonal causes, it is a category 2 indication. And thrombocytopharesis is only a bridging therapy, mainly for patients who are unresponsive to cytoreduction or other first-line therapies. And again, each procedure of the apheresis, thrombocytopharesis, can reduce a platelet count by 30 to 60%. And usually 1.5 to 2 total blood volume will be processed during each procedure. And here also the frequency, it can be done daily or till the goal is achieved. And it's usually done when the platelet count goes above 10 lakhs. And in the case of an acute thrombohemorrhagic event, the goal should be the normalization of platelet count or resolution of symptoms. For high-risk patients, it should be decided on a case-to-case basis. And in this patient, a single thrombocytopharesis procedure was able to bring down the platelet count by 76%, and only a single procedure was performed, and the patient was then after that followed up in the hemat-OPD, and he is doing well. Coming to the next case, it's a 62-year-old male with acute leukemia with a total count of 2 lakhs, and he presented with symptoms of leukostasis. And again, leukocytopharesis was done for the patient. Again, for hypoleukocytosis, if it's a symptomatic patient, it's a category 2 indication according to American Society for Apheresis guidelines. And when it's done prophylactically, it's a category 3 indication. So in hypoleukocytosis, the patient can present with tumor lysis syndrome, with the tumor cells releasing its contents into bloodstream, and or the patient can have DIC or other symptoms of leukostasis, mainly dyspnea and other pulmonary symptoms, neurological symptoms, etc. And for AML patients, leukostasis can occur when the WBC count is more than 1 lakh, but the subtypes, myelomonocytic and monocytic, it can occur when the count is more than 50,000. And leukostasis can be graded based on the severity of symptoms, pulmonary and neurologic. Coming to the rationale for leukocytopharesis, with the procedure being done, there is a rapid reduction of the intravascular leukemic cellular burden, and this improves the tissue perfusion, and there is a rapid reversal of pulmonary and CNS manifestations. And like the procedure which was mentioned before, here also a single procedure can bring down the WBC count by 30 to 60%. And usually RBC transfusion prior to the procedure is avoided, as it can increase the viscosity. And in anemic patients, red cell priming is used. That is a red cell unit that is compatible with the patient, cross-match compatible, can be used for priming the machine. Coming to the next case, it's a 45-year-old female who presented with progressive ascending weakness of both lower limbs since 2 days, and she gives a history of fever 2 weeks back, which was managed symptomatically. And on examination, the power was grade 2 with absent deep tendon reflex, and a probable GBS was considered, and later it was confirmed with further investigations. And Guillain-Barré syndrome is again, the primary treatment is therapeutic plasma exchange, which is again a category 1 indication according to ASWA guidelines. So coming to therapeutic plasma exchange. So what is the rationale of the procedure? The main goal is to remove antibody with harmful specificity, to remove protein with harmful physical properties, to remove toxins, and to correct deficiency of plasma factors. And when the substance to be removed is intravascular, accurately we can predict how much volume it can be removed. But less decrease than expected occurs when the substance is IgA, that is when it's distributed extravascular to intravascular. A greater decrease occurs with fibrinogen, complement components, etc. And there is no change when the substance is potassium or glucose or bicarbonate. And usually 1.5 to 2 volume plasma volume is replaced, and even with 2 volume exchange, about 86% substance is cleared, and more than 2 volume exchange, usually it's not done because the rate of substance clearance is not very significant, and also the side effects associated is more. So usually 1.5 to 2 volume exchange is done. So the factors affecting the efficacy also, IgM, more of it is intravascular, and a single TPE procedure can be done. And for IgG, when it's when a longer interval is, when procedure is done in a longer interval, there's a greater benefit. And these are the data that is captured from World Apheresis Association registry. They have compiled data from more than 1 lakh procedures, and they have observed that the side effects associated with various therapeutic procedures in apheresis has significantly decreased over time. In 2003, it was 11%, and it has come down to 2.3% in 2018, mainly because of more awareness about the procedure, and also because of more modern equipments and technology available. So this is a summary on the therapeutic procedures associated with the case scenarios we have seen. So basically, therapeutic apheresis is a life-saving procedure, but it's often underutilized. It's usually done only in higher centers, and so awareness has to be created, and evidence-based practice has to be adopted, and it has to be decided on a case-to-case basis. So the next case is about a goal-directed therapy in massive transfusion. I have just taken a small example because patient blood management is a highly evolving specialty in transfusion medicine, and with Neeraj sir has already spoken about the applications of TEG and ROTAM in various scenarios, and the entire thing is beyond the scope of this discussion. I have included a small example. It's a 43-year-old male with history of RTA. He has blunt trauma abdomen, fast positive. He was in hypovolemic shock, Massive transfusion protocol was initiated. Exploratory laparotomy performed. These were his lab investigations. And since he was hemodynamically stable, massive transfusion was initiated, and 6 RBCs, FFPs, platelets, and 10 cryos were transfused before viscoelastic hemostatic assay was done, that is TEC. And as Sir has discussed the different variables in it, we'll just see in this what is prolonged. And here, the normal values are also given here. The LY30, that is fibrinolysis, is happening extremely fast here. That is what is happening. And a consultation was sought, and the advice given was tranexamic acid 1 gram IV stat, and also to continue transfusion support as the patient was hemodynamically unstable. So this is a TEC tracing, it was already discussed. So I'll just brief on how to decide on transfusion therapy based on TEC parameters. The R time when it is prolonged, it indicates that the clotting factors are deficient in the plasma. And when the coagulation factors are decreased, patient has to be supported with plasma 10 to 20 ml per kg. When the angle is decreased in comparison with the normal, the fibrinogen level is decreased. Again, patient has to be supported with either cryo or FFP. When the functional fibrinogen maximum amplitude is decreased, again the same thing, FFP or cryo or even fibrinogen concentrates can be given. When the TEC maximum amplitude, kaolin TEC maximum amplitude is decreased, platelets have to be given. And when lysis 30 is prolonged, then primarily hyperfibrinolysis is happening, and tranexamic acid has to be given. Like in the above case, it was given. And if the patient is a heparinized patient, then protamine sulfate can be given. So these are the benefits of TEC, mainly lesser turnaround time. It gives an impression of the in vivo coagulation part, and the difficult part to be analyzed, mainly fibrinolysis is assessed with TEC, and real-time clot development is visually developed, and it's cost-effective as well. But it's not widespread used. It's used only in higher centers. There is difficulty in standardizing and validating a normal value, and also the baseline TEC assessment is very important. So there is difficulty in quality assurance. A trained personnel is required, and there is limited EQUAS data also. So coming to the last scenario, this is a very common scenario encountered by many physicians as well. And coming to transfusion medicine part, while issuing an incompatible red cell unit, a lot of technical difficulties are there, starting from blood group discrepancy till cross match, and also there will be pressure from the clinician side as well. As the patient is severely anemic, blood transfusion will have to be given at the earliest. But there will be several difficulties which prevents that, and we will see that. It is autoimmune hemolytic anemia. So red cell transfusion is always a big challenge in autoimmune hemolytic anemia. Always it's a challenge for the physician as well as for the blood center medical officer. Because I'm not going into the details, the patient will be having an autoantibody which causes a blood group discrepancy, difficulty in cross-match, antibody screening, and it will be impossible to issue a compatible unit of blood. So, and a transfusion should not be denied as well to a patient. So, when transfusion cannot be avoided, the best match unit should be given to the patient. Earlier used term was least incompatible. Now the best match is a term used. So when issuing an appropriate blood, many number of red cells will have to be cross-matched with the patient, and you will have to look in which unit the reactivity is showing less than that of the autocontrol, and that unit will have to be issued to the patient. And if possible, phenotype matched blood should be issued to the patient. But that is also not possible in all centers. So this is a outline. Whenever there is a need for transfusion, if the patient has an autoantibody and transfused in the last 3 months, an alloadsorption has to be done. And if the patient was not transfused, an autoadsorption can be done. And if there is an alloantibody present, we should try to identify the matching and provide ABO and RHD specific or compatible blood should be given. Phenotyping should be done. But again, all these will not be possible in day-to-day practice. So these are the procedures that are done when a sample comes at the blood center. And again, it is a very tedious process. And it has to be communicated with the clinician regarding the time-consuming and the difficult procedures involved. And as all the procedures are complex and antisera may not be involved, may not be available, and for the clinician, the patient will be presenting with severe anemia and he might be needing us emergency transfusion. And so the best thing to do is to give a best match unit and to observe the patient closely for signs of hemolysis. So inform the clinical team, as said, about the compatibility testing and the complexities, and the transfusion will be safe, and the survival of transfused RBCs will be comparable to the patient's RBCs as well. So that's about a difficult transfusion scenario that was encountered most often in our clinical practice. Thank you.
Thank you, Dr. Lashmi, for giving the latest aspects of transfusion medicine practice, including specific care in specific scenarios. I think it is lack of awareness among physicians when to consult a transfusion medicine regarding specific scenarios, and that is the reason I think most of the services are underutilized. I think we need to educate the physicians, the pediatricians, and those who are taking care of these type of patients to timely consult the transfusion medicine consultant regarding their need. I think then only these services will be utilized. And other issue is the availability of these type of resources in small centers, because unless and until they refer these type of patient to promptly refer these patients to a higher center, these can be utilized. That is also another. Is there any questions specifically to Dr.?
Thank you, Lakshmi. It's a wonderful presentation. All the cases you explained in detail. I just want to ask you, what about the photopheresis?
Okay, photopheresis is not routinely performed, and I think it's very rarely done in the country itself. There what happens is that, again, it's a form of therapeutic apheresis. The required blood component can be extracted via apheresis machine, and it can be subjected to ultraviolet radiation and 8-methoxyseralin treatment. And it's basically an immunomodulatory therapy, and it can be infused back to the patient through apheresis itself.
Indications?
I think it's done for cutaneous T-cell lymphoma. It's done. I think it's a category 1 indication according to ASFA. Then acute GVHD, it's given as an indication, but it's not routinely practiced.
Thank you.
A nice presentation. You said about best match, best match, just an auto control, something you used to know. What is that auto control?
So auto control means we are testing the patient's.
Can you show a slide?
Yes. So this is column agglutination technology is a principle that is used here, and here in auto control, patient's own cells and serum is made to react at 37 degrees Celsius, and we see and we check for the reactivity pattern or the grade of reactivity, how strong it is reacting, and then at the same time we will be doing the DCT ICT, everything will be positive, and a multiple number of units will be checked for compatibility. And all of them will be incompatible, and we'll have to see which unit is showing a lesser reactive strength when compared to the auto control.
Okay, thank you. One more question. Exchange, you said about hemochromatosis, no?
Yes, sir.
What is the rationale for that?
Rationale is that again to avoid overload, the exchange is happening, and 50. Our goal is to bring ferritin less than 50. So with exchange, it is possible to acquire that with less number of procedures in a shorter span compared to whole blood removal compared to therapeutic phlebotomy.
So you will be removing what?
Red cells as such. Only red cells will be removed, and back can be.
How exactly it helps? I didn't follow.
Sir, with the apheresis machine, we'll be collecting blood from the patient. With the help of the machine, it will be centrifuged. Only red cells will be extracted.
Yeah.
Back will be infused back to the patient itself. And so, with that, it can be the goal of to bringing down the ferritin to less than 50, I think it's a limit. It can be done faster, and it can be achieved at a faster pace compared to therapeutic phlebotomy.
Okay. Thank you.
So any more questions to?
Thank you, ma'am. I'd like to welcome Dr. Shilpa Abraham, Assistant Professor Pediatrics, Head of Pediatrics Intensive Care Unit, to felicitate the speaker and the moderators. Thank you, ma'am. I welcome Dr. Bobby Abraham, Senior Resident Raktam, to deliver the vote of thanks.
It's almost lunchtime and everybody's hungry, and I would wrap it up very short. And on behalf of Team Raktam, I would like to express our heartfelt gratitude for everyone who made their presence felt today. Special word of mention to Dr. George Chandi, Dr. Sijo, Reverend Father Sijo, and MS Office for their immense support. To Dr. Vikram Matthews for brightening the day with his wonderful oration. I would like to thank all the academic luminaries who both chaired the session and moderated the session and spoke today, enlightening our knowledge. We extend our heartfelt gratitude as a team to all of you. Our special word of thanks to NATCO as a major partner for this event, and MCure, who is an associate sponsor for this event. I would also like to extend my heartfelt thanks to the operations department, graphics, IT team, Srikanth and team, lights and sounds, for making this event a grand success. Finally, last but not the least, I would like to thank Team Raktam for doing such a wonderful program in such a short notice. Thank you, one and all.
Thank you, sir. The event was engaging, informative, and thoroughly enjoyable. Your expertise and dedication contributed to its success, and we're grateful for the time and energy you put into making it a memorable experience. On behalf of Team Raktam, we express our heartfelt gratitude to each and every one of you for attending Hematology Horizons. Your presence and participation has made this event truly exceptional.
Please do join us for the lunch. Food coupons will be provided to all the delegates who are not members of the staff at the counter. Please do have a great day ahead.